Is the sound better now? Hello.
Sir, please start.
Good evening, everybody, and welcome to this webinar that AIOS is hosting, titled Back to Ophthalmic Practice, Roadmap to Recovery. As you all know that the COVID-19 crisis has plunged everybody into an uncharted territory, uncharted waters, which we had never expected or thought that such a thing will happen in our lifetime. So what we have to really look at is that the lockdown has now been extended at least till 20th of April, and then it will go on till 3rd of May, depending upon a partial lift down of the lockdown. So this is posing serious challenges both psychologically as also mentally and financially to all of us. So to discuss as to what are the likely outcomes and how we have to keep afloat in our practice as also in our family as also ourselves, and how do we gradually open our OPD and OT, etc. We have a great panel of people by which we are going to share their experiences. So first of all, let me introduce you to three guest faculty, three panelists who will be talking about economics, management, as also the legal aspects. So first of all, we have Mr. Kaustav Ganguly, who is the managing director of Alvarez and Marshall, which is one of the very big consultancy companies. And he will be giving us his overview as to how the economy, etc., is going to work. Then we have Mr. Kashyap Pujara, who is the executive director, head of research for Axis Capital Limited, Mumbai. He's also very well versed with healthcare, and he's going to talk about what he feels are going to be the outcomes and the way the recovery is going to happen. And for the legal aspects, we are going to have with us Advocate Mahendra Kumar Vajpayee, who is an advocate at the Supreme Court. Within the AIOS, we have panelists, and the entire governing council is there with you, plus some more panelists and experts who will share their knowledge as to what they feel is the likely outcome and how we are going to come out of this crisis. So I'll be participating as president of the All India Ophthalmological Society. We have Dr. Barun Kumar Nayak, who is the president-elect of AIOS and also the head of Department of Ophthalmology at the PD Hinduja Hospital, Mumbai. Then we have Dr. Lalit Verma, who is the vice president of AIOS and the director of the Vitreous Retina Services at Center for Sight. We have Dr. Professor Namrata Sharma, who is the honorary secretary of AIOS and also a professor of ophthalmology at the RP Center. We have Professor Rajesh Sinha, who is the honorary treasurer of AIOS and professor of ophthalmology at RP Center. Dr. D. Ramamurthy, who has been a very active past president of AIOS and he is the chairman of the Eye Foundation. Dr. Shri Ganesh, who is the chairman and managing director of Netradhama Group of Eye Hospitals from Bangalore. Dr. Ratish Chandra Paul, who is the secretary of the Sushrut Foundation and Research Center from Kolkata. Then we have Professor Natarajan, who is the immediate past president of AIOS and also the chairman and managing director of Aditya Jyoth Hospitals. Dr. Partha, who was earlier ARC chairman and now is the chairman of the scientific committee of AIOS and is the director of BBI Foundation, works as a group practice. We have Dr. Chitra Ramamurthy, who is the chairman of the ARC AIOS and the medical director at Eye Foundation, Coimbatore. We have Dr. Santosh Hanover, who is the editor of the Journal of AIOS, as also he is the director of the Medical Services Center for Sight Group of Eye Hospitals based out of Hyderabad. We have also with us Dr. Arup Chakravarti, who is the editor proceedings of AIOS and the senior consultant Chakravarti Eye Care Center, Trivandrum. We have Dr. Malika Goyal, who is a senior consultant and head of Vitreous Retina and Uveitis at Apollo Hospitals, Hyderabad. Dr. Ajay Arora, who is the joint treasurer of AIOS and director of Vision Plus Eye Center from Noida. And we have Dr. Chaitra Jayadev, who is the joint secretary AIOS, as also a vitreous retinal consultant at Narayan Netralaya, Bangalore. And finally, we have Dr. Preetham Samant, who is now the president of BOA. He is the consultant in ophthalmology from PD Hinduja Hospital, Mumbai. And representing the young ophthalmologist is Dr. Karan Bhatia, who is an assistant professor and consultant at Sitapur Eye Hospital, UP. So these are the people who are going to participate. So let us first start with the talks by two of the experts from the financial and management market. So let's start first with Kashyap Pujara, who is the head of the equity research at Axis Capital. So Kashyap, do share with the AIOS members as to what you feel, what is the problem, how big is the problem, and what do you foresee?
Thank you, Doctor. And ladies and gentlemen, thank you so much for having me here. Before I move on to how your businesses would get impacted or how the healthcare industry would face the impact because of COVID, let me delve a bit into what is the state of the economy we are currently in. So even before this COVID actually hit us, we were in a situation where the economic activity had slowed down last year. We were clearly cyclically coming off from on the growth front versus what we used to grow at earlier. COVID has only accelerated the growth slowdown incrementally. Now, given the lockdown that has kind of come in at this point in time, in all likelihood, April is lost. While there could be a possibility that 20th April onwards, you will see some partial ease down on the lockdown front. But 400 out of 700 districts would still remain in severe lockdown mode till 3rd of May. Incrementally, there will be a supply chain issue. Labor paucity is very much visible. So practically, in our view, May is also kind of going to be in virtually lost mode. You lost the entire May as well. So Q1 of the year is something which I would kind of write off. And there would be more or less, depending on industry to industry we are in, there could be anywhere between 20-25% to 70-75% drop in the revenues of different companies across this particular period. So now what this does is that the GDP of the country, which most of the economists before COVID outbreak, happened, we had kind of pegged the GDP growth for FY21 as far as India is concerned at 6%. We are now looking at negative GDP growth in the current year. Could be in the range of 2%, could be even lower. That depends on how long does it take for the businesses to come back to normalcy. But what this means from a number perspective is that we have got our first recession in the last 40 years. It was, I think, in the 1980s, maybe 40 years back, where we saw negative GDP for India. We are actually gone back to that point that after 40 years, we are now going to be seeing a negative growth. What this implies for businesses is that consumption is going to be severely restrained. Consumer confidence has been shaken. And unless we find a vaccine to kind of, lift the sentiments up and get the confidence back, it's going to be difficult for consumers to go and consume in the same way that they used to consume earlier. So discretionary spends will be cut down, which would definitely have a bearing on all your practices as well. Capex is going to be cut down as well. So most of the corporates that we talk to are clearly going to be pushing back Capex. So with Capex going down, consumption going down, definitely there is growth, which is, in negative, is very much warranted in the interim. Now, incrementally, as far as healthcare providers are concerned, I think the way to look at it is that you are having a business which is largely a discretionary spend-driven category. So if I am an eye doctor and I am actually getting patients for cataract or LASIK, it would be fair to assume that your businesses would be pushed back because consumers or patients will not want to spend that money in the current point. They will try to absorb the pain and kind of just push the elective surgery or the LASIK to a later date. Having said that, there would still be a set of customers who would want to, or patients who would want to kind of come in and do the surgery done. For that, I think as a doctor, two things we need to ensure is that you need to be available and you need to ensure that your facilities are safe so that patients don't feel a risk of coming in to get treated because of COVID-19. So what I know for sure that leading hospitals like Apollo hospitals are actually thinking of doing pre-COVID screening, wherein before any inpatient comes in for any normal procedure, they will get a pre-COVID test done. And unless he's negative, they will not kind of take him on board. So these are some of the thoughts. None of them have implemented it, but these are some of the thoughts which are kind of going around in the healthcare community. And it could be something that one could look at, given that you would want your staff, yourself, and all your patients to feel comfortable. So safety and availability is one side of the bargain, but at the end of the day, one will have to also see that your practice could possibly come down by 60 to 70% or even 80% in first quarter. In the second quarter, it could be down by 50%, which means that if you are doing 100 rupees in one quarter, in the first quarter, April to June, you could be at 20 or 40. In the second quarter, that 100 could be as low as 50. In the third quarter, that number could be in the range of 80, 90, and you will maybe be more than 100 in the fourth quarter. That is how I see the curve of revenues for discretionary spend categories. Obviously, the severity of this curve depends upon industry to industry, but wherever the patient or the discretionary consumer can push his consumption, he will push. So to that extent, one should be prepared for the worst, and that is the kind of revenue one should keep in mind. Now, what this means as a doctor or as any businessman is that you will have to run your business or your practice for cash and not for profits. You will have to ensure that you have the liquidity to kind of manage the 1-2 quarters, absorbing all the costs. Your medical, your staff generally at most of the ophthalmologists or doctors end are not very high end in that sense that, so I wouldn't kind of say salary cuts, but typically wherever you can cut costs, one should cut costs. This is a good time to kind of build in liquidity. If you are strapped for liquidity, I would kind of suggest to incrementally, ensure that your credit lines are in place. If you have a sanction line, but you're not drawn it, please draw it now, don't wait, but need to have sufficient liquidity on hand. Incrementally, I feel that the businesses which were on burn mode, wherein Ps were funding a business which was actually having a cash burn, that typical funding will go down. People will not be enthused to burn cash in the interim. However, as far as healthcare is concerned, I do see a M&A possibility which will open up mergers and acquisition, because you will certainly have some players who are more stronger than the other players, and there would be a large section of players who might not have the relevant funding in place. So there could be a merger and acquisition opportunity. My only request in such cases would be not to be anchored to a particular multiple. Many times we have a multiple in mind for our business, but these are unprecedented times. Right now, managing the business and remaining afloat is, I think, more important than actually being anchored to a valuation multiple. That's all from my side. Maybe we can have some question and answers.
So thank you very much, Kashyap. So what we will do is that please send your questions, because both Kashyap Pujara as also Kaustav are with us for about an hour. So based on their two presentations, please do send in the questions and we'll ask them. So that was the bird's eye view of Kashyap Pujara from Axis Capital. And now let's go on to Kaustav Ganguly. Kaustav is looking after healthcare. He's the managing director for Alvarez and Marshall, and he has a very, very deep knowledge about healthcare as also about eye care. So Kaustav, all yours.
Thank you, Doctor. Just by way of introduction, so my name is Kaustav Ganguly. I am a managing director with Alvarez and Marshall. Alvarez and Marshall, or A&M, is a global professional services firm based out of New York, and we advise both corporate groups as well as investors on their issues and opportunities in the healthcare sector. Now, quickly pivoting to the situation at hand here, I think the first question that we are really asking ourselves at an overall level for the Indian economy and for the industry is, where is the end in sight, right? And when is it that one can potentially expect a bounce back? Now, nobody has an answer to that question, but I think it's important to note that we have been in touch with our China office, and we have been closely watching the Wuhan experience. I mean, especially as lockdown got lifted. What do we see is the bounce back that is happening across different sectors and industries and in retail, right? So what we do realize is that Wuhan, even after the lockdown got lifted, it is taking really long for most of the industries and the sectors to start coming back. For the reasons that Kashyap mentioned. I think he did talk about the fact that even as the threat of the virus itself goes away, I think people are going to be very, very cagey about their discretionary spends for some time to come. And I think we are starting to see some of that play out in China, specifically in Wuhan. Secondly, I think what we have also realized is that even as the lockdown gets lifted, you do not necessarily get all of your operational labor back to run your manufacturing plants and factories, simply because for example, there are certain restrictions which are still in place in China, which would continue to happen even in a place like India, right? So for example, your district to district movement is still somewhat restricted, and even as a migrant laborer in China, when you're coming back to Wuhan, you're supposed to self-quarantine for a period of 14 days before you can join the factories. And that essentially means that most of the factories there or plants there are still operating at a low level of capacity. The other thing that is likely to happen here, as it is happening in China, is that there are serious pricing degrowths that are happening. So for example, if you take retail as a sector, right? I mean, that had taken a hit of almost 90-95% degrowth at the height of the crisis. Now it has come to around 65% in terms of volumes, but the sale is still only about 40-45%, and that basically is an indication of the fact that a lot of the retail formats which were sitting on inventory are essentially doing some very heavy discounting to push through their inventory as quickly as they can, right? So some of that is also likely to play out in India. In India, obviously, as in other parts of the world, as this crisis started panning out, I think the sectors that got hit really badly to start with was, aviation, hospitality, retail. I mean, especially the discretionary retail, restaurants, food services, right? So those sectors really got hit badly. And initially, I think at least people were under the impression that something like healthcare, and by healthcare people were referring to both healthcare services as well as pharma, would be a little insulated from this crisis that is playing out. However, the experience on the ground has been very, very different, right? So to start with, I think for pharmaceuticals, the extent of the impact of the hit has been somewhat less for a couple of reasons, right? One is obviously, these are still classified as essential services and essential products. And especially when the lockdown happened, I think initially at the beginning of the lockdown, there was some panic buying and hoarding by consumers, which led to some hoarding and order placement by retailers as well as stockists, which led to, at least in certain therapy areas, your pharmaceutical sales going up a little bit, if not at least staying constant. Obviously, in therapy areas like dermatology or dentistry, you could see that those therapy areas were clearly seeing the impact of a downward trend. But in many of the acute as well as chronic therapy areas, the businesses was only to the extent of, let's say, 10, 15, 20%, not more than that, which is quite a bit of a revelation compared to most of the other sectors that you're looking at, right? Now, what has happened with both medical technology and as well as with pharma, and I will move to healthcare services and then to eye care services also in a bit. What has happened there is that their plants are essentially suffering from the fact that a lot of the plant laborers, majority of whom also used to be migrants, have essentially vanished. So all of these plants are actually operating at a lower level of capacity. So today, most of these plants, so I'm currently, let's say, working with one of the largest Indian pharmaceutical companies. They are working at 45-50% of plant capacity, right? And that's essentially an outcome of the fact that their migrant laborers in the plant, I think they have vanished, and therefore they have had to arrange for these laborers actually staying inside of the plant, so that they do not pose a threat to themselves as well as to their colleagues. So their travel is restricted. They are staying inside of the plant. Their lodging and everything has been arranged inside of the plant, and they continue to basically operate the plant through multiple shifts. The other area where obviously the Indian industry is getting impacted, and this is true for medical technology as well as pharma, is the supply of components or intermediaries or APIs, especially where you are dependent on inputs of components coming through from Japan or a Germany or from a China, or even from from across different states within India. That supply chain has been hit very, very badly. So your ports obviously declared force majeure. Most of our ports are essentially lying completely clogged up because the regular transporters, okay, who would have picked up that traffic from the ports and would have transferred to a CFA or to a distribution go down. That that transportation capacity is currently working at 25 to 30% of normal capacity. So a lot of these drivers who are actually flying these trucks, they essentially 40% of these trucks were abandoned on the highways, and they were basically just abandoned on the highways, and these drivers went home, with the result that your overall regular road transportation has been hit very badly. And because of this whole port congestion as well as the transportation having been hit so badly, even essential products and services like medical technology and pharma has clearly been hit. And our sense is that as and when you come out of the lockdown, as things start coming back, even then that reverse migration of migrant labor is going to take a little bit of time, right? So for things to come back to normalcy, we expect at least a couple of quarters, if not more, even post the lockdown, right? So that's essentially what is happening on medical technology and pharma. Healthcare has been obviously hit worse. So if you look at healthcare services, specifically the multi-specialty hospitals or the hospital chains across the country, pretty much for all of them, I think your outpatient volume has crashed by more than 90%. Your inpatient volume, depending on who you're talking about, has crashed by anywhere between 40% to 80% plus, right? And the degree of impact is obviously different for different specialties. So if you look at, the more elective-oriented, specialties like eye care, or if you were to look at in vitro fertilization, I think those have taken bigger knocks. There you're obviously talking about a 95% to 100% kind of an impact, right? Whereas there are certain specialties which are less elective in nature. So very interestingly, something like, let's say, birthing or obstetrics has not taken as much of a hit. I was talking to two of the larger private equity industry chains in the birthing space only a few days back, and it seems they have been able to manage their show quite well for a couple of reasons. Obviously, because birthing can't wait for anybody else for lockdown or no lockdown, and secondly, also because it's not a specialty where there's a large degree of drainage from outside of the city or from different parts of the state back to your hospital. So that has been more insulated. Whereas even things like orthopedics obviously has been hit pretty bad. Anything which is non-trauma, non-emergent in orthopedics has been pushed out, right? So your hip, knee, spine surgeries have all been pushed out, and our sense is that orthopedics will take the longest amongst the key specialties to bounce back. Cardiac has also been hit for some of the non-emergent elective procedures, like angioplasties have been hit really badly. What we are hearing from hospitals is that obviously you can't stay that forever, right? So something like your CABGs and angioplasties in cardiac sciences is expected to start bouncing back around early to mid-May. Oncology is something that people would have expected to be completely bulletproof. We've been proven wrong. Okay, so oncology for existing patients, they obviously continue. So whoever is undergoing, let's say, a chemotherapy service or a radiotherapy service, they continue to undergo that service, right? I think you can't obviously break that chain or session. But when it comes to new patient registration, some of the oncology focused players have seen almost 65 to 70% of volumes drop in new patient registrations, and essentially what the reason it has dropped by 65-70% is because most senior oncologists are saying that the absolutely critical 30-35-40% of patients who cannot be made to wait are the ones who are still coming in and registering, where the rest of the guys who can still wait are being made to wait, and that extent of wait in oncology is at least 2 to 3 weeks. So most oncology-focused businesses are expecting a bounce back to happen within a 3 week to 4 week kind of a time period. Obviously, assuming that drainage is allowed to happen, because like with a lot of other specialties, like in eye care, like in many other specialties, oncology is also largely dependent on drainage patients coming from different cities, different states into the larger cities and getting their services. So once the lockdown goes away and as patient movement is allowed, I think some of these specialties will start bouncing back. The key point here is what once again Kashyap mentioned, which is that a lot of these multi-specialty hospitals also are in a slightly precarious situation when it comes to their cash positions, right? So they had a certain cash balance. But given the extent of the knock, if somebody is operating at, let's say 30, 35, 40% kind of occupancy levels for their hospital setup, you would obviously imagine that, within the next 2-3 months or thereabouts, their cash reserves will get wiped out, unless, of course, you essentially draw upon the lines, which is where I liked what Dr. Kashyap was mentioning, which is that if you do have the ability to kind of take new lines from banks or financiers, you must do that right here and now, and you should not wait for later. So that's a quick snapshot of what we are seeing is playing out in healthcare services. More specifically, closer home, when it comes to eye care, I think the impact has been absolute. I think probably as much as what we've seen in some of the other elective specialties like IVF. IVF is the only other close comparison that comes to my mind, where most of the large chains, I think they have seen their impact to the extent of 85-90% or thereabouts, right? I think whoever we are talking about have seen that level of impact, principally because whatever could have been pushed out by way of cataract surgeries, retina surgeries, or LASIK for sure have been pushed out, and this obviously very few of your procedures will actually be emergent in nature, which essentially means that you don't see some of these patients essentially coming back in a hurry. Like it can happen in cardiac, or it can happen in gastro or neuro, or definitely in onco. You do not see some of these bunched up demand to immediately come back to you within the next 3 to 6 month kind of a time period. So that being the context or the background, I think what people are doing on the ground in healthcare services is as follows. I think today I just got off a call with a large private equity investor which has got a portfolio in healthcare services as well, and I think most of these investors are now starting to explore a difference in the engagement model. So whenever there are specialties where there's a high fixed doctor cost, I think promoters and businesses are starting to think about whether I can start pushing some of my minimum guarantee or fixed doctor model towards a more fee for service kind of a model. So that's something that is happening, especially with some private equity industry chains, because people are trying to cut their losses and trying to figure out if they can have a more variable model versus a fixed model, right? So that's one. Second thing, on nurse technician costs, I don't think people have done anything about it yet, especially because people are still trying to be compassionate with your larger workforce and trying to figure out how you can retain this workforce once the demand does come back up. But at some point of time or the other, we at Alvarez and Marcel feel that some of our private sector operators will be pushed into considering what is happening in the UK, which is a furlough system. So there, there is a provision for some of your employers to send your employees on furlough, which is essentially leave without pay. But with obviously your basic essential services and medical pay and all of that being covered by the government. Obviously here the government does not pay for that, but people are starting to explore, at least in their mind. At least I know of an eye care business in India, which is consulting their lawyers to figure out if there can be a model where they can start either cutting employee pay or basically sending some of the employees to a leave without pay kind of a model, right? So that's the second option that people have started thinking about or started considering. The third thing that is a bit of a no-brainer for pretty much all of us, that all healthcare services players are doing, is that they're asking for rental holidays. Okay, everybody. I mean, whether you talk about some of the largest corporate chains, right down to some of the smaller single specialty players, everybody without exception are going back and asking for rental holidays, pushing off your rental payments, and even asking for considerations where your rental rates are being renegotiated and cut. So that is definitely something that is happening. And the fourth thing that people services players are doing is that they are trying to scale back their level of operations. So as they try to scale back their level of operations, adjusted for 15, 20, 25% occupancy, obviously their overall utilities costs, power costs, those costs obviously are being scaled back a little bit. Probably less relevant for an eye care kind of a setup, but definitely those are 3 or 4 of the mechanisms that people are thinking about or have started implementing already to ensure that they have their nose above water, that they have cash to survive with over the next 2-3 months, right?
Okay. Kaustav, yeah. We are having a lot of problem listening to you. Is your mic? Can you come nearer?
There is some internet issue at his end. Please.
Okay, start again. Yeah.
Okay, doctor, when did you lose me? Can you hear me now?
Yeah, it's better.
Okay. I don't know where you lost me.
No, we didn't lose you, but it was getting interrupted. Anyway, go ahead. You last couple of points I think you're wanting to make.
Yeah, I think the last couple of points that I was wanting to make is, beyond this whole, very stringent focus on cost optimization, which I just explained to you, your doctor costs, nurse costs, technician costs, and other overheads. I think people are pushing out their payables the best they can, right? Pretty much all players are starting to take a very hard look at their working capital situation and trying to basically push out non-essential payments. They're definitely pushing out all capital investment. So I over the last 5 days I would have spoken to about 14, 15 of these corporate hospitals. All of them have deferred all of their capex until things start looking up. In terms of patient engagement, very interestingly, what some of these guys have started doing is that they have started using a digital channel and a home care model to reach out to their elderly comorbid patients, and now is as good a time as any other for patients on a B2C basis, rather than expecting other doctors to refer patients to you, because that channel is in any case broken, right? So therefore, on the revenue side, there are a couple of these multi-specialty hospitals who have started partnering with online pharmacy companies to identify chronically ill patients who will need their services, and have started using a digital platform to reach out to these patients, do consultations, do diagnostics, because these chronic care patients will continue to need their services. A similar thought process can definitely be employed in eye care, because you don't see your outpatients coming in. Probably now is as good a time as anything else, right? I mean, for you to do some of these digital channels and reach out to your patients and engage with your patients, so that when the demand does come back up, you can probably stand to benefit from that demand bounce back versus some of your peers or competitors. So that's really a quick snapshot of what we are seeing at an overall level in the economy, specifically in healthcare services and more specifically in eye care. I'll take a pause here and see if you have questions now.
There are a lot of questions. I think Kaustav and Kashyap, you can answer. Is Kashyap there? Yeah, he's there very much. Okay, so one question that comes in is that how long, in your opinion, we just need a ballpark figure, would it take for the practices to come back to normal? 1 quarter, 2 quarter, 3 quarters, or longer? Kaustav, for an ophthalmic practice to come back to what it was, how long, according to you, would it take? 1 quarter, 2 quarters, 3 quarters, 4 quarters, or maybe longer?
Yeah. Kashyap, you want to go first?
No, in my view, ideally for things to come back to normalcy, you will need a cure or a vaccine to basically eliminate this problem at hand, and for people to feel confident of going out with their normal consumption patterns. Given that we don't have that information when it is likely, and making a guesstimate that by the end of this year we would surely have a vaccine supposedly at hand. Keeping that in mind, I think normalization should happen from the 4th quarter of this year. So 2022 is when the normalization would be. So in my view, 1st quarter is severely down. 2nd quarter, you will have some return to normalcy, but it will be 50% below normalcy levels. And from the 3rd and 4th quarter, you will start seeing the bounce back. So I think at the current point in time, the way I'm seeing is 2 quarters are completely going to be under a severe crunch. So from a practice perspective, you'll have to manage it for your cash and not for your profit. And you'll have to cut your cost wherever possible.
Kaustav, what's your take?
Yeah, so I would think that for specifically for eye care, I would not expect a bounce back to happen before Q3, and that too, when I say a bounce back, I don't expect the revenues to go back to your regular 100% levels by Q3. My sense is obviously Q1 is a bit of a wipeout. Q2, you will see some of the other healthcare specialties starting to bounce back, right? I mean, things that you cannot push out any further, non-elective in nature, highly critical, highly acute. I think those things will start bouncing back. Eye care less so. I still expect eye care to be in the 2nd quarter to be around 25-30% of where you normally are. Q3 is probably going to be greater than 50-60% if I can hazard a guess. I mean, nobody really knows, but my sense is that you're looking at least Q3 to Q4 before you can start thinking of normalcy, given the largely elective nature of our services.
Okay, one question from Dr. Anand Shroff from Mumbai. He is asking, cash flows have stopped. Should a single practitioner or a 2 practitioner practice, should they take out their own personal wealth to pay salaries, or they should do something to reduce the salary cost? So that means that they do not have any cash reserves in the company. And should they be using their personal wealth to pay the salaries to everybody, or they should ask the employees to chip in? Kaustav?
So, Dr. Shroff, my sense is that that's a very personal choice, right? I mean, essentially where you're saying that you would obviously deplete your personal wealth to ensure that you're taking care of the pillars of your business. We are essentially seeing different businesses react to this differently. In all honesty, I think I won't name anybody because some of these are some of our very large clients, but one of the largest business groups in India, conglomerates, right? They are not necessarily in a happy situation from a cash perspective. I think all of these businesses are trying to take a view of how long can I keep surviving, right? Can I survive for another 3 months, 4 months, 11 months, whatever it is? They have done their assessment, and what they are getting is not a very happy picture. But despite that, I think, they are essentially going out and saying that, no, we will continue to not fire anybody, and we will cover everybody's costs, everybody's, salaries. Obviously, there can't be any promotions or increments, but we will cover all of our workforce. Now, that's a very business group and promoter specific choice. There are other companies, Dr. Shroff, who are already starting to consider whether it's going to be legally okay for them to start cutting down on employees and their salaries, simply because, from the government's end, I think the government is obviously talking about be humane to your employees and do not fire anybody, do not kind of cut their costs. Whereas obviously individual small businesses are going belly up, right? And therefore, at some point of time, sooner rather than later, very quickly, they will have to make some of these individual personal choices.
Okay. The one question that comes, I think, Kashyap, maybe you can answer. They want to find out, somebody has asked a question about investments into equities at this particular moment. It's not concerned with ophthalmology, but they're asking about should they invest in equities?
It's a fair point. So I think the overall backdrop as far as equity is concerned is that we are in the same economic pocket where things are going to take time to pick up. So purely looking at the next 2-3 year picture might not be right, because we have to first survive the fall in the current year. Having said that, it's not about the valuation problem. The valuations across many companies are more reasonable now than what they were. But the problem is a flow problem, wherein, like even Costa was saying, the problem is how you end up surviving the next 1 or 2 quarters, because what is the kind of cash that you have on hand, and what are your fixed costs, where are your fixed costs like, and with the steep revenue drop, how long will you be able to survive that without taking on additional debt? And second, do you have room to draw additional debt? So with all these multiple questions in mind, I think the way to look at equity is that, yes, you can look at equities. There are a couple of sectors, there are a few sectors who will be severely impacted. There will be few sectors who will be relatively lesser impacted. Having said that, look at companies where there are no governance issues, where you can trust the promoters and the management. They are clean companies. There is reasonable cash on balance sheet. You don't want to get on to any levered business at this point. You need companies with high cash balances. And obviously look at companies where the profitability is inherently high. Because in such times, companies where margins are wafer thin, or profitability or return on capital is low, they would actually be under severe pressure. So companies who have better profitability, better margins will be able to absorb the shock better compared to the others. And obviously companies where you can get a combination of companies with better profitability and zero debt would be the best positioned here to kind of look at it. So I would not get into stock specific on this forum, but that is the way I would kind of look at it at this stage.
One final question I would wish to ask is that somebody has asked, supposing somebody has to make an investment from his personal wealth or personal savings into buying a big ticket new technology, should he or should he not make that, and should it be postponed or a loan should be taken? How should one look at making new investments into eye care?
So
or Kashyap, maybe
again, this is dependent on how the person's capitalizations. In as far as I can suggest is that as long as he's adequately capitalized, he can still go ahead and make that. But as I said, cash, we don't know how deep the problem can be, whether it is third quarter or fourth quarter. We typically don't know. And hence it would be better to just wait and push back the capex decisions for now rather than incurring capex at this point in time.
Okay, Kaustav, you said that a lot of companies are, or a lot of healthcare people are wanting to change the fixed cost into variable cost. Would that be something that is from a doctor perspective? Would that be something that you would suggest? That means that linking the payouts be linked to how we recover to doctors?
Yeah. Obviously, I mean, you can't do that now because obviously, as a specialty which is largely fully elective dependent, almost. And obviously most of the eye care businesses are completely gone.
इसका तो ये खराब है क्या दूसरा वाला
डॉक्टर वाजपेयी प्लीज आप बोलिए मत, उसको ऑफ कर दीजिए अपना ऑडियो. डॉक्टर वाजपेयी, मिस्टर वाजपेयी. ओके, कौस्तुभ, जस्ट आंसर प्लीज.
Yeah. So not to start with, given that most eye care businesses currently are looking at a severe loss, right? I mean, you're looking at a 75, 80%, 90% wipeout in your volumes. But as you come up, you're absolutely right. As you come up through Q2, Q3, my sense is that some of these businesses will start pivoting a little bit more towards a better mix of variable versus fixed, because a lot of the eye care businesses, at least traditionally, were largely fixed doctor costs, right? And my sense is that the normal has already moved. So you will see some of these businesses pivoting more to a variable plus fixed kind of a model as you go ahead.
Okay. And I think, Kashyap, one final question for you. They say that healthcare is relatively recession proof, but among healthcare, I think eye care would be a more elective surgery, so may take a little longer. So the question is, when do you think the private equity would start looking back at the eye care business?
Clearly, I think private equity at this point in time has reasonable amount of firepower still left, so they do have the money on them. I think they are going to, wait till the business kind of returns to some level of normalcy and some normalized numbers can be stacked out. Because at this point in time, it's too difficult to even draw a forecast, and it's all about how long can one survive. So I would say that it would take, I think, 1 or 2 more quarters, maybe in Q2, Q3, people would start again looking back at this pace. At this point in time, I think for the smaller players who are small, setups, for them, I would rather say M&A with larger players who are consolidating and who have cash on hand would be a better opportunity. And with people who already have the PE infusion with them currently at hand. For new incoming PE at this point in time to scale up would be kind of difficult because they will not get into a cash burn mode at this point in time.
Fine. Thank you very much, Kaustav. Thank you very much, Kashyap, for sparing your time. Indeed, a pleasure that you answered questions. And we'll love to have you sometime again, as and when you have time. Thank you very much.
Thank you.
Okay.
Thanks.
Thanks. So let's come on to the small panel discussion that we have from the panelists, and let's go on to this. And this is Dr. Lalit, Dr. Malika, and Dr. Karan Bhatia. So Karan from a young perspective, Lalit from 60 plus, and Malika from 50 plus. So what is the future of the practice patterns that you feel that will be there? Support and Jaswinder, I am not getting to log on to the server for the questions. I don't know if something is wrong. Namtak, are you?
They've changed the link just now. I've got it just now. Even I couldn't log on to the question.
So just send it to me because the question stopped coming. Okay, Lalit, what do you think will be the future of practice patterns? How do you think they are going to change?
Is my video not coming?
Sorry?
So
Yeah,
He says you can't start.
I'm stopping the share. Yeah, go ahead. Lalit.
He says you can't start.
No, you can.
So you can start now.
I have stopped the slide share. That's why you were not able to start. You can
Again,
start.
go back.
Can you see?
Again, go to screen.
Can you see?
No, so you have to
Lalit,
share the screen.
your video is off.
So you have to share.
Oh, you're fine. Okay, you have connected by 2 devices. Yeah, Lalit, we can see you, but we can't see the slides. Are you showing any slides?
Yeah. So it is there. Slide is there.
You have to open the slide and then share screen. Open your PowerPoint presentation on the.
PowerPoint is open, Namta.
Now then click the green button, share screen, which is downstairs, down on the down.
6 o'clock position.
On the ribbon down.
6 o'clock.
Share screen. 6 o'clock exactly.
Yeah.
He has already
now.
done it.
Now you press on the PowerPoint.
Yes, sir. Yes.
Is it there?
Yes,
Yeah.
sir.
Yeah.
Okay.
Yeah.
You see, we just had very nice talks by Kaustav and the other person. Believe
Kashyap.
me, future is not going to be the same. We, for I think 1 or 2 years, all the practices are going to take a back seat, and we have to redefine. And there has to be a new calibration and new normal also. There's always a debate between life versus livelihood. See, the nation today, Modi ji and all are planning to save life, but what about livelihood, which is lacking? But I think in some time in the a week or so, as Mahipal was saying, we have to start slowly. But my priorities from surgery point of view would be still slow, priority to one-eyed and more emergent patients. Obviously, observe all the mandated precautions which you all know, sanitation, mask, and etc. But stagger your surgeries. No crowding in the OP. Prefer topical versus local versus GA. And PPP is, I think, for ophthalmology is not a must. You see, PPP is quite cumbersome and it makes your movements very cumbersome movements. Only if there is a definitive COVID patient or a suspect or some messy surgery like DCR and all, then maybe PPP may be required. But full PPP in a routine cataract or even VR surgery, I don't think so is a must. Extra precautions we should all take, as we do in HIV patients, like double gloves, etc. But because the basic aim always is to reduce risk, not only to yourself, to your staff, which is very, very important, and to your patients and attendants also. There's a lot of controversy what all investigations to be done, because a lot of people, in fact, our anesthetists also says COVID screening is a must for all. And I know of a lot of hospitals, which includes Apollo as well as Gangaram now, which says COVID for all the patients. But I thought pre-op X-ray chest or CT chest may be better. And always have to have a high-risk consent. High-risk consent is a must, which includes regarding potential for that patient can become COVID positive. But believe me, negative report does not rule out COVID, as happened in Indore. There were 2 negative reports. Again, the patient had a positive report and ultimately he died. I thought COVID screening test report does make sense for GA patients for longer surgeries or patients with diabetes or where immune status comorbidities is there. Further, attendance is a strict no, and they can easily wait in the car. The other thing which I thought is seniors may have to work more, and every day some extra hours will have to be put and work even on holidays. And I think all of us should volunteer about the deductions and deferred payments or ESOPs. The other thing is, for YOC point of view, bedside teaching may suffer. The surgical hand-ons also will take a back seat. Can be compensated by webinars, as AIOS is doing. The role of telemedicine is bound to increase. I'm happy that AIOS already has done a lot of inroads into this. This is especially not for new patients, but follow-up patients. And I personally believe this should be a paid practice. Otherwise, you will be bombarded with questions. It has to be a paid, so that you have to learn how to open that portal for payment. We all know it has been legalized lately, but be careful. Although legalized, but it still comes under CPA. Patients can still sue you. So all of us have to learn this art of and have a payment platform also. So just to conclude, keywords are start slowly, but definitively. Prioritize, take extra precautions. COVID testing, I think, will become a must for some time at least. Fast and safe surgery has to be the norm for some time. And more working hours we have to be prepared for, and also be prepared for salary cuts and layoffs. And telemedicine has a good future. Thank you very much.
Thank you very much, Dr. Lalit. May I request the other speakers to kind of just sum it up in 3 minutes? Dr. Malika, please.
Yeah, Dr. Verma has to stop his screen sharing.
Lalit, you have to get out of screen share.
Yeah.
Okay. Thank you.
Are you able to see my slides?
You are sure? Yes, we can.
Okay. So Dr. Verma was speaking mainly for the...
Put it on the slideshow, Malika.
Yeah. Dr. Verma was speaking for surgeries, and I'm going to speak for OPDs. That is how we had divided the topics. So what we have to understand is that all these changes are not going to be for 1 month, 2 months, 3 months. We are looking at over a year. because the risk of this virus spread is not going to go away when the lockdown is eased. It will go only when there is a vaccine, and that vaccine has not even been possible for SARS and MERS yet. So we don't even know that there will be a good vaccine. And herd immunity as a concept does not apply here because of its morbidity and mortality. Even China, when they have released their lockdowns, they are seeing a second wave. And in fact, in China, a lot of patients who had recovered from the virus and had tested negative have again got the virus infection. So there's not even an immunity in a given patient, it seems. So the risk of transmission will remain high till there is a vaccine. So we are looking at all this for at least a year and maybe more. Now, we cannot go on not seeing patients because there are patients who have these problems which cannot wait indefinitely. So what we can do is, in the OPDs, we have to have a very light OP, minimize the number of patients per hour. And this we can only do by categorizing the appointments based on the urgency of the indication. So when the receptionists are giving appointments, they have to be trained to understand the urgency of the appointment and give accordingly. And take, say, for retina, not more than 4 appointments an hour. This will allow you to social distancing in your waiting lounge, no crowding. And also the waiting time for the patients will also be kept minimum because they are exposed in the hospital area to the infection risk. And why we also need more time is because we will be spending more time per patient because we'll be cleaning, disinfecting in between patients. So as Dr. Verma said, we may have to increase our working hours per day and work on other days as well. So as I said, we'll give appointments based on the urgency of a patient. We will be filtering the appointments. And this can happen mainly if we all shift to electronic system of appointments so that we know what we already have for a given day and we don't crowd the patient. We can give the appointments more systematically. That has to be done now. Walk-ins have to be minimized to prevent crowding. So we will all have to have a better way of giving appointments. And then at entry, we will have to have only one entrance into a hospital system so that there can be a screening where somebody can ask the basic questions, record the temperature. There should be a wash basin and a hand sanitizer that every patient has to take advantage of. And masks have to be given at the entrance. And a new thing which will come in the outpatient will be COVID consenting. They will have to take the risk of in contracting the infection. Otherwise, they will not be taken into the system. So disinfection between the patients will include of the slit lamp, any area where the patient has contacted, examination chair after he leaves, scleral depressors, lenses, and the optometrist will have to do the same. Assistants will have to disinfecting between the dilating drops that they keep putting to patients. So all this will increase our time per patient, and hence we need to see less patients per hour. Now, counseling and examination will change. When we are examining the patient, we may not even need the attendant in the room. And when we have seen the patient, we can have the attendant, but only one. There should be a minimum gap of 2 meters with the attendant when we are speaking to them. Speaking has to be minimized also because that is the source for aerosols. Other option is to keep, after you have examined the patient and after a brief discussion, the further counseling can happen on a phone while the patient is in another room, or via video conferencing if you can have it. So all discussions can happen without sitting in the same room, even post-surgery counseling in the same manner. And very important is that minimizing now having these files which are running from the reception to the optometrist to the workup and the consultant. Instead of hard copies, if we can just fill up the EMR, and this is how it reaches in a soft copy to the consultant, that will minimize the transferring of the viruses through the fomites. And also the advantage is that we can generate an e-prescription from this EMR and send it to the patient's email or WhatsApp if they don't want a hard copy, and also to the hospital pharmacy so that the patient just goes and says his ID and his prescription is ready there. Those who don't want this, of course, they can get one paper prescription also. So this is to minimize the risk of transmission of the virus. So we will have to move more and more into electronic systems. Teleconsultations will be very important. For non-urgent problems, we can have a fixed time of the day where we will talk to our patients. And if they are non-urgent, we can give them an appointment after 1 month or 2 months. And we can do several follow-ups without having to see them. And this will allow revenue generation because these teleconsultation systems will have an payment built in. Thank you.
you very much, Dr. Malika. We'll now go on to Dr. Karan Bhatia. Karan, do you have a presentation or are you just going to speak?
I'll just speak, sir.
Go ahead.
Yes. So, as everybody has said, and the previous two speakers have put a very good light on the subject. Definitely, we will be suffering a lot post-COVID, and this is because most of the patients are the routine and elective ones that has also been covered. But unless it's an emergency, patients will not come to our hospitals, especially in the urban educated areas. If you go for the rural setups, however, the story can be a bit different, and because they're right now also we are having sometimes in the emergency there can be a surge of patients, particularly once the lockdown lifts, because there will be a lot of cases of corneal ulcers, particularly in the rural areas, who are not being treated, and likewise some post-ops also who would require to come, and the educational information of them, they would not, sometimes it does not reach the extreme rural areas of the country. So basically, our patient clientage will decrease. Telemedicine is a very good option. Video appointments, consultations have to be done. So basically, we have to digitalize ourselves and keep in touch with times. We will have to, a lot of apps are available, like the Practo being one, or we'll have to adopt different apps by which we can stay touched. Another important thing is that we should be concentrating on our old patients rather than the new patients. So simply, a person can be appointed where that person will be calling up your old patients, and you ask them, how are you doing, are you okay, specifically the ones that you've operated, and just showing that we care about you. And then once the lockdown lifts, that you can tell them that the routine OPD services have resumed, you can take appointment, and that is only when you're supposed to come and see. But when we just show that we care, we will not lose out on our old patients, and therefore we should concentrate on our old patients rather than our new patients. Apart from that, we will be having a lot of some things that we have to go, as they have summarized, is we'll have to revisit our working hours. We will also have to multitask our staff to work minimally, because you will have to give them rotational times during the COVID times, particularly for hospitals, and particularly young ophthalmologists. There'll be a problem because most of them will have, who have started their own practices, will have some sort of a loan, and they'll have to pay their EMI. So they have to, it's a big challenge for us. So you have to start now, start developing a reserve fund or a contingency fund, by which we will be able to, because this can happen again. So we will have to prepare also for the next time that this can be done. We will have to collaborate amongst our colleagues, and even who are our previous competitors, because at this time we'll have to all come out as one, and basically we will have to show that message out. We will have to also increase, because our operational expenses will definitely increase. So we will have to what we'll have to do is avoid all unnecessary purchases that are there. Along with all that, the premium surgeries will definitely go down. So we will have to reduce the cost of premium surgeries, particularly cataract surgeries, so that the numbers come up, and because people are also having a sort of a recession here. So we will have to somehow reduce the cost, so that somehow we can get the numbers and build our cash with that. And our prime focus, particularly for the young ophthalmologists now, will be our practice. We'll have to concentrate. If anybody else of the young ophthalmologists are visiting different centers, they will have to stop and just focus primarily on their own center, because it's going to take a while till we get back. Thank you.
Thank you very much, Karan. That's a nice sum up. I think Lalit, Malika, and Karan, all three did a great job. So since we have the advocate, Mr. Mahendra Kumar Bajpai, with us for a limited time, we'll just go over, we'll take the question. There are some questions there, but we'll take the questions a little later. So Bajpai Sahab, welcome to this. He is a senior advocate at the Supreme Court, and maybe you could just give your initial thoughts, and I can request all the people who are watching to please send questions regarding the law that they wish to ask. So to start with, Bajpai Sahab, would you want to say something, or should we go straight to the questions? Doctor?
I think we had decided that I'll be speaking a little bit on the telemedicine practice guidelines that have been notified.
Yes.
Some very key factors. All channels of communications can be resorted to by doctors. Emails, WhatsApp, fax, mobile. You can speak with the patient. You can speak with the patient's attendants. You can speak with other doctors. You can speak with nurses. What is very important as far as telemedicine is concerned, is that the option of resorting to telemedicine will have to be in accordance with your professional judgment. And for that, you may be taken to court or whatever legal consequences follow. As far as prescribing medicines are concerned, this telemedicine practice guidelines has classified medicines into 4 categories. And depending upon whether the patient happens to be the first-time patient or a follow-up patient, you can or you cannot prescribe certain medicines. Be very cautious in prescribing medicines and do look into this list, which obviously will keep on getting updated from time to time. Signed prescription has to be sent to the patient. It can be sent either by email, it can be sent either by WhatsApp or by any other means. Do keep a copy, and if you can give a number to this prescription, it is well and good. You have all the rights to refuse for telemedicine consultations. So if you are not comfortable with the patient, you have all the rights to say no. At the same time, the patient also has all the rights to say so. Much more than that, even during the course of a telemedicine session, both the patient as well as the doctor, both have a right to stop it. You obviously have a right to charge your fees, and you must be charging your fees. The guidelines say that to practice telemedicine guidelines, you will have to do course, which will be offered by the Medical Council of India. But as of now, no course is required. During this COVID pandemic, you can certainly practice. That is one aspect. You can certainly not use this telemedicine for any invasive procedure. So it's a big no for invasive procedures. Detailed guidelines are awaited, and then only we'll come to know about the finer aspects. But as of now, this should suffice. Yes, Dr. Mahipal, I'll take your questions if there are any.
So I have a question, and that is, suppose you're doing telemedicine and you realize that it's not working, in the sense that you advise the patient, but a patient needs a physical consultation. So you've already charged for telemedicine. So for a physical consultation, can you charge again when you call the patient for a physical consultation?
Absolutely, you can.
So
because ultimately, as a professional, it's your time that is important. You have given your time in telemedicine, you are going to give your time for physical consultations also.
So Dr. Nayak and Dr. Rajesh Sinha, you can take over from here. Rajesh, you are muted. Rajesh, you are muted.
Yeah. Good evening, everyone. And Mr. Bajpai, good evening. Now, one thing that you really highlighted about the telemedicine, but the problem in ophthalmology is that telemedicine has 2 ends. One is a doctor's end, where you get the input, but input has to be put from the patient's end. Unfortunately, in ophthalmology, means most of the patients, they come with 4 major complaints. We'll say either vision is down, eyes are red, there is a irritation or pain in the eye, or discharge from the eye. But we don't have finding, because only on these basis, we have to examine, and then only we can give some opinion. But because we don't have system at the patient's end, then how do we give advice? And whatever advice we give, if there is some wrong advice, then what will happen? So that is something which is a major issue, because LBP model is something different, where they have got primary, secondary, tertiary level of system. So at the primary level also, there is someone a trained technician who can feed in the data, and from tertiary center, they can give advice. So this is what one question which I have, and which probably everyone to consider, all ophthalmologists, how to go about telemedicine. We are talking a lot about telemedicine.
So Dr. Nayak, please understand, till now giving advice on telephones, etc., was not at all permissible in this country. At least that has been made legally permissible. Now, all these things that you are saying will slowly evolve. So maybe a senior, as of now, obviously for ophthalmologists who really want to see the eyes, one option could be, there could be a other doctor on the other end. If he is not an ophthalmologist, obviously it becomes a big problem. because then the terms that you ask him, he may not be able to understand. So on those aspects, obviously, you may not be able to use telemedicine that effectively. You are right in that. But slowly things will evolve.
So Vajpayee, there's one issue that if somebody charges money for telemedicine and somebody doesn't charge, will there be a difference as far as legal implications is concerned?
Legal, you mean to say whether the patient can sue or not sue?
Yeah.
Yeah, patient is going to sue if anything wrong happens.
But
how are you going to say? How are you going to say I did not charge? The patient, obviously, in a court of law, will say this is a charger. This is a doctor who was charging money with everyone. Even I was charged, and the doctor did not give me a receipt. That these are the very common allegations that are made in court.
Sir, I have a question. Mr. Vajpayee, sir, in case in ophthalmology, as Dr. Nayak put it, we cannot examine the back of the eye and sometimes details of the front of the eye. And the patient insists on teleconsultation that give me what is your diagnosis, and we cannot come to a diagnosis. And when we tell the truth that we can't diagnose you, what is the status that time?
You have all the rights to say you have not been able to diagnose.
Okay, so that's what I told my consultants, that after talking everything, and if you don't have proper data, and I told them we have to insist that they have to be examined if it is an emergency by a nearby hospital.
Absolutely, that's the right way.
Thank you.
Mr. Vajpayee, what is force majeure? Like, can you just tell us details about it?
Force majeure, simple terms, means act of God. Something that is not that you have done, God has done. So this pandemic is force majeure. This will be invoked in many of the contracts between parties. So I am unable to do my contractual obligation because of force majeure. So don't penalize me. It would be something like this.
So will this pandemic be considered in that, in terms of
absolutely
insurance and
it's a force majeure.
Okay.
So the question.
So let me put this force majeure into your practice. Supposingly you have been delayed in diagnosing, and the patient suffers because of that. There was a surgery which was scheduled. You have not been able to perform it, and because of that, the patient has to face adverse consequences. Here the defense, this doctrine of force majeure, will come to your rescue.
So the question was related to rent in a small practice. So even if you don't have a force majeure clause in the rent, that somebody is running a clinic in a rented place, can he stop paying the rent with or without a force majeure clause?
It will depend upon the judge who decides that. Because in nearly all the tenancy agreements, etc., you have those clauses that in case of force majeure, so and so things will happen. If not, then it depends upon the party.
Okay.
What is your take on a routine COVID testing for all the patients? Legal point of view.
No, so the government of India has come up with a guideline. You cannot do routine testing. Anyway, we have very few laboratories. So at least for the next 2 or 3 months, our facilities are stressed out. So your routine patients who are going to come, if you are going to put them to COVID testing, it will overburden the already overburdened system. Okay. I think on 23rd or 21st, the government of India has come up with a guideline.
I think getting COVID testing is
the reason I asked this question was, suppose a patient becomes positive after the surgery for some other reason, because he contracted from outside, and he alleges that I got it from the hospital. That is the issue.
No, that is fine. The hospital will always have a defense, and I don't think any court is going to grant compensation or hold the hospital or doctor negligent. The COVID is there. No one knows from where the COVID would have been contracted by the patient. Okay. See, even in case of nosocomial infections, courts are not very ready to hold the hospital negligent. If you have done your protocols, courts accept the patient may get infected.
There's a section 269 of IPC which states that even unknowingly, if you cause spread of infection, then you can be held liable. So is it true in these cases in this pandemic?
See, at least for doctors, this won't be applicable. You can take it from me, 269 and 270. Yeah. Both of them won't be applicable. It would be applicable to other cases.
Okay.
Then, Mr. Bajpayee, about now I'm coming to different legal aspect about the liability, because there are some staff in the hospital, doctor in the hospital. If during the course of their services, if some of the staff develops positive, then what is the liability which the hospital has to, is any liability to the hospital?
Absolutely. There is a liability under the labor laws. There is a liability of the employer if something wrong happens to the employee during the course of employment. What would really save the hospital or a good defense would be that they had taken all the precautions. Personal protective equipments were made available. There was no scarcity. In fact, that is what we are observing today in nearly every hospital, that PPEs are not there in good numbers.
So what do you suggest? Should we take a consent from all the staffs that...
that is not going to help you.
Okay.
No, so what is going to help, sir?
Pray to God, what else?
No, I think...
No,
Ajay, as he said, we have to follow this thing, like whatever required, Malika Goyal mentioned about OPD, you have to wash your hands and give an instruction, make sure that it is being done.
No, the question was, when you have a disaster management act, that applies to the patients as well as to the staff. Now, if a patient who comes to the hospital acquires an infection, we can say the patient may have acquired outside. Similarly, the staff is going home. They may have contacted with some other people. How do I know they have acquired in the hospital?
That's correct. So
see, if I was the advocate for your staff, I would have said, you forced me to come to hospital. While there was a lock-in, all other professionals, all other employees were at home. I was forced to come there.
No, sir, but right, I am in Noida. We have received a letter from the Chief Minister.
Absolutely. So that would be your defense.
That the clinics have to be kept open. Do I defy DM? Do I defy Chief Minister?
So that letter, if at all your employee goes to the court, that will be your defense, and the court will decide.
Okay. Dr. Nayak, you have any questions?
Yeah. I do. I was a similar thing, that about suppose the hospital insists that you have to come and attend to the patients, and you as a precaution, because now as a precautionary measure, you think, no, right now there is not to the hospital and attend to the patient. Now, can hospital force us to do that?
See, there would be two categories of doctors. One, those who are on payroll of the hospital, obviously they would fall in a different category. And the ones who are not on the payroll, who are consulting consultants. Much more than that, it would also depend upon emergency and non-emergency. One more factor that would be taken into account is whether the safety of the doctor can be assured by the hospital, or the requisite steps have not been taken. The requisite equipments are not there. And all this will come into play. See, right now, till the time ESMA is invoked, Essential Service Maintenance Act, a professional can always say, no, I am not going to come. Legal consequences will follow.
No, but what's the option for an employer? Like if the staff goes to court, so what's the option? What should an employer do? As a precautionary measure, that it's very difficult to prove that every precautionary step, as you know, that PPE etc. are not freely available. So it's very difficult to prove that everything was there available. So what all should an employer do so that he doesn't land into trouble?
See, two things. Number one, whatever communication has come from the government that you should keep yourself open, just preserve a copy of that. That will always be there as your defense. Whatever you did, it was not voluntarily. It was out of force from the government. That is why you were doing it. Number two, if you have procured those PPEs, if you have got your hospital fumigated, just keep the records. And if you have asked and it is not available, keep those records. These all will help you in proving that whatever could be done, you have done. Now, if things could not be procured, it was not in your hand.
So I have a question. There is a lot of confusion about PPE and the action which we are doing in the hospital. For a particular act, in various stages of examination or operation of the patient, different sets of PPE is required. So if our society comes up with guidelines saying in OPD you should have this, examination you should have this, can that work as a legal benchmark?
Right now, no, because the government of India has come up with a specific guideline. What
they
is
have
the
not come up.
PPE?
They have
It
not
should
come
not
up
be
with
contrary. No, they have.
not for ophthalmology, sir.
So they have said OPD and so on. So they have given very nicely. They have classified this thing. Don't be totally inconsistent or contrary to what they are saying.
Okay.
There's one. I have one more question, sir.
Yeah, Rajesh, final question, please.
Yeah. There's a lot of discussion about the salary cut for the employees and all that. So if the employee doesn't agree for this, or if the employee, says that he doesn't want to agree for that, so can an employer do salary cut? Will it go for a? I mean, can he be legally liable if he cuts salary in spite of the employee telling no?
Yeah. So even the Honorable Prime Minister only made an appeal.
Yes.
There is no force of law behind it. If the employee has his casual leaves and paid leaves and so on, then you will have to give it. You will have to pay that money.
And what happens after the casual leaves are exhausted, sir?
So then whatever are the normal labor rules, that those will take care.
No, like you said, the employee is sitting at home, the hospital is open, the employee doesn't come in. So should the employee be marked absent?
Absolutely.
So if the employee is marked absent, should he be paid?
See, there are employment rules in this country. If they permit, you have to pay, then you have to pay.
No, because
and if they don't permit you, see, there are two things. One are the rules or the laws which are in existence. And the second aspect is your contractual relationship with that employee. And based on both of them, you can or you cannot cut his salary.
No, because of the Disaster Management Act being invoked, and he can say that there's a lockdown, I cannot come. But if we are saying no, there is a lockdown, we get you a curfew pass, you can travel. So what happens then?
So in spite of that, see, this, I have my own doubts, though I am not an authority, number one. Number two, in a pandemic like this is the first time India is facing this pandemic. And the reported judgments are far too less. We don't know which way our law is going to speak. It will be after 5 years that we will come to know, look, in so-and-so situation, if an employee did not come to his hospital, these were the consequences. But as of now, it can be very safely said, there are two things which you have to see. The employment laws, service laws which are applicable in this country. And number two, your contractual agreement with that employee. And based on that, you will have to take a decision.
So if the contractual agreement says that there is a force majeure clause with an employee or a doctor, so this comes under force majeure, that you are not able to perform that contract?
He will try to take shield. It depends what he will try to take shield, and then you will say you have not come. That was not force majeure. I was giving you the passes. So this is all what advocates will keep on arguing it.
Okay. So fine. I think one important point that you made was that the Prime Minister regarding retrenchment has only made an appeal and it's not an order, right? Is that so? Is that
not
so?
only retrenchment, even to give salaries. That is what he has said.
I don't think he mentioned anything about salaries yesterday. He just talked about retrenchment. Be compassionate to the employees is his appeal, and no retrenchment was his appeal. That's what I. Anyway, Dr. Nayak, would you wish to thank Dr. Bajpai or anything else you?
Yeah, so one thing I just want to make final comment that after this, even if the lockdown is over, the life is not going to be same and everything will be looked upon as with a vision of suspect. So someone who is just in front of you, you are not sure means whether it's really infected or not infected, any surface you are going to touch, any mall you are going. So life will be entirely different. And so we'll see how does it emerge. And I thank Mr. Mahendra Vajpayee for taking out his time and giving some of his opinion. And also means everyone can log in on the AIOS website. Some of the questions that he has answered is short answers will be uploaded on the AIOS website. So that also are quite useful, directly related to law and our practice. Thank you, Mr.
It
Vajpayee.
is already uploaded. It is there on the AIOS website. So anybody who wants to see can see the question answers.
Okay, thank you very much, Mr. Vajpayee. We'll go on to the next section, and that is what the AIOS survey has shown. Namrata, do you have the slides, or should I carry on?
Yes, sir. Carry on, please.
Okay, so actually this is not fully in sync, but what we have to just say is that single surgeon practice, the people, there were about 1,500 people, 1,419 responses that have been there. And 731 of these were single practice or were working in a group practice. So this 215 which shows here is in group practice, and this is single practice. So you can see about 2/3 of the people who replied were working as a single surgeon practice or as a freelancer. And then if you look at the age, you can see that it's an equal. So 20 to 30 is the least, but otherwise the split of the people who have responded was pretty much equal. That means that between 31 to 40, 41 to 50, and 51 to 60, and 60 plus. We had about I would say about 8% of the people who replied were residents or fellows in training. Now let's just say because multiple choices were available, we had more of the people who were doing comprehensive and cataract and refractive. We had a lot of people from retina also and glaucoma who were answering. Now, what is important for us to see is that the number of patients that were being seen in the pre-COVID era, you can see that majority of the people were seeing about between 1 to 20 is here. Then you see 21 to 30 is here. That's about 19%, 31 to 40 and 51 to 60. So you had almost an equal split of the people seeing between 1 to 60 patients in the pre-lockdown. But what is important here is that 41.8%, that is 593 respondents have seen 0 patient. That means that the OPD in 41.8% of the respondents is 0. And the percentage dropping to less than 25% is 55.7. So there are very few here who are seeing patients up to 26-50%. But what is important is that you are seeing about 96-97% of the doctors or the ophthalmologists not seeing any patients or below 25% of their normal OPD. Now, what is also important is that 69.4% of the ophthalmologists are just seeing the emergency OPD, and that is something which is very, very important. Though about 9% of the ophthalmologists who have responded are still continuing to see their routine OPD, and 22.6. So if you combine this 22.6 and the emergency OPD, you are looking at about close to 92-93% of the ophthalmologists who are responding, not seeing any OPD or only emergency OPD that is there. Now, when you are consulted about a potential, this is just that how many, so 87% of the ophthalmologists have yet to come across any patient of COVID, nor have they been consulted for any patient of COVID that is there. And in case they are consulted, what you can see is that all the methodologies are being used by the ophthalmologist, whether it be by phone or whether it be by email. Video consulting has gone up. But WhatsApp and phone, these are the number 1 and 2 methodologies by which you are seeing the ophthalmologist contacting or the patient contacting them and them giving the advice. Now, if you look at the number of surgeries, that was the next question that was asked, that what are the number of surgeries that you were performing in a month. You can see that there were a large number of ophthalmologists who have responded. They were doing less than 20 surgeries a month. And you can see 21 to 40 is the next number, which is 23. And then you have the other groups. But let us come to what it is happening now. So what is very, very important is that the number of surgeries has dropped dramatically, and 87.1% of the respondents of 1400 plus have done no surgery at all since the lockdown is there. So this is something very, very important, that surgeries and OPDs have fallen to almost 0. And only the 12.4% people who have still done these surgeries are 1 to 15% of their normal average that they were doing. So this is something very, very important that you have to understand, that the impact to ophthalmology has been very, very significant. And that is what the respondents ophthalmologists are saying. Now, if you look at this, 72% of the ophthalmologists are saying that they have done no surgery, as was said earlier, and 24.4 are of those who said they were doing surgery are only emergency surgery. However, the next big chunk that is coming is that about 6% of the ophthalmologists are still doing anti-VEGF injections. So these are the three categories: no surgery, only emergency or anti-VEGF. The rest have elective surgery, only 1.3%. So that means about 2 people might have, 2 to 5 people might have replied there. Now, what are the measures or protection that the staff has taken is most of them are wanting to be isolating themselves or work as separate teams. So they have divided themselves into teams and the working hours have been significantly reduced. Now, what is also very important is that the guidelines that AIOS has issued is being followed by more than half the people. So 50% of the people are following the guidelines which AIOS has given. Now, let us look at the future practice behavior patterns that we ask the question. What is here that is coming out is that almost 50% of the people are saying that they will incorporate phone and video consultation in their future practices, and they will decrease the frequency of the patient coming in. So 2 things that are coming out: they will want to do more of non-physical, non-touch consultations and reduce the amount of number of, so if you had 4 post-op visits, maybe reduced to 2. And 2.2% of the ophthalmologists are saying that they will go and do bilateral cataract surgeries, while about 30% of the ophthalmologists are saying that there will be no change in their practice pattern as regards after the pre-COVID and the post-COVID era that is there. Now, these are just some of the things. I think it's nothing specific, but whatever were the guidelines, these are the precautions that majority of the people have taken. Now, when you look at telemedicine, the question that was being asked, only 9.5% of the responding ophthalmologists are saying that as of today, they have started to use telemedicine or teleophthalmologist or teleophthalmology on a large scale. However, about 37% are saying that they have started using it, but on a limited scale. But the intent to use teleophthalmology is there in another 28.4%. And only a quarter of that is 24.9% of the respondents have said that they will not be implementing telemedicine or teleophthalmology in their practice. Now, as you can see that the number has shifted. So it has now, if you see that they are using it either on a large scale or they are using, if you combine these two, on a limited scale as compared to what it was pre-COVID. So pre-COVID, 77% of the ophthalmologists were not using teleophthalmology. That means that they did not have access to teleophthalmology prior to the COVID. So there has been a sea change of people wanting to move towards teleophthalmology in the post-COVID or in the COVID era that is there. Now, this is the next question that was being asked. So as a voluntary part, so 67.1%, this is about the take homes as to the people who are employees. So that means about 2/3 of the people who were responding were not employees. So they were basically single practitioners or in a group practice. So, or they were having a variable component from a multi-speciality hospital. So this does not apply to them. But out of the 33% that was there, you can see that almost everybody, all ophthalmologists are willing to take part in the difficulty that is there as regards COVID. So willing to take cuts was 16.1%. So mind you, this is 67 is out. So out of the 33%, 16.1% were willing to take salary cuts. And there were 15.3% of this 33%, who that means half of the doctors were willing to work extra hours in the post-COVID to somehow make up of the losses that are there. And then if you see, we were asking deferred payment. That means one is taking salary cut and the second is that you get deferred payments with financial milestones. That means that if the company or the practice achieves particular milestones, so that is another 11.1. So that is about, if you remove the 67, so out of the 33, so that means 1/3 of the people were willing to take deferred payments in addition to salary cuts, which would be there. That means that if the milestones are achieved, but 6.3%, that means about 18 or 20% said that they do not want any milestones with the deferred payment that is there. Now, The next thing which Dr. Santosh is going to talk, we are having a slightly different outcome. That means that the anxiety level, we asked them what is the anxiety level of the ophthalmologist today. And their anxiety level in a scale of 1 to 5, there were 30.7% of the people who went on to anxiety level scale of 3. There were about 25%, that means a quarter, who had very little anxiety, and there were about 7.2% who had the maximum anxiety as regards the COVID. Now, what were the anxieties because of? The maximum number of anxiety is that you could have the fear of spreading the illness to patients and your relatives. So this 36.2% is the maximum anxiety that people or the ophthalmologists are having, that they can spread it to their staff, to the patients, and to their relatives. So that is the important thing that is there. And if you look at the other two outcomes, this is that if you get COVID, you will have to self-contain yourself, or you could self-contaminate yourself and quarantine yourself. That is the next big anxiety. And the third big anxiety, that is 22.2%, is that there is going to be a significant stress on the personal and practice and the finances of an individual. So spreading illness, having contamination yourself, and having the practice and your personal finances being hit, these are the three important things that have come out in 1421 responses that we have. Now, the next question that we asked was as regards the satisfaction level with what AIOS has been doing so far to try to bring the people on board, the ophthalmologist, as to giving guidelines, to keep webinars, to keep them motivated, etc. So what you can see is that a scale of, if you go from a scale of 6 to 10, you can see that it is 90% satisfaction, and there are a lot of people who feel that AIOS has done exceedingly well in taking the concerns of the ophthalmologist, and this is what are the figures that you have. So if you look at a scale of 8, 9, 10, you have almost 60% people saying that. Now, what is important that another question that we asked them was that what guidelines or whom are you looking up to provide you specific guidance in the COVID era? And 64% of the respondents said that they are looking up to All India Ophthalmological Society to give them the guidance. And discussions with colleagues is the second one, which is 21.7%. So this is what people are saying as regards whom are they looking up and whom are they consulting for guidance. Now, the next question that is there is, do you foresee a significant change in your practice and type of employment post-COVID? And you can see that 63%, 62.2% of the people feel that there is going to be a significant impact. There is going to be a change in the way you practice and the type of employment that you have, while about 38% feel that there will be no change, it will be the same. So this is what we have as regards the survey which has been conducted by AIOS. And without breaking here, I think we'll go on to the second survey that has been conducted by IGO. So I think I'll ask Santosh to, I think he also has a similar about 1,600 people responding to that. So let us just go on to Santosh for giving the preliminary outcomes of the survey of IGO.
Yes, sir. Good evening. This was a survey conducted by AIOS and IGO on psychosocial well-being and professional well-being. So we had about 62% response rate of those who opened the email and clicked on the SMS link. And until I analyzed at 3 p.m., there were 1,950 responses. Majority of these people happen to be practitioners. As you see here, 80% are practitioners, and postgraduates also were there, and they composed a minor number. Now, there was a pan-India distribution with representation from all the states and union territories. 75% of ophthalmologists or respondents were in metro or tier 2 cities, and rest of them were distributed elsewhere. Solo practice and family or group practice constituted about 40%. Corporate employees were 20%, and NGOs, etc., were another 20%. Now, who is affected and how? If the question asked was, if you are a PG student or a fellow, is your training affected during COVID-19? And the respondents were 413. And a majority of them said that their training was considerably or completely affected. The second question that was asked was, if you are a PG student or a fellow, is your teaching institute supportive during COVID-19? There were not responses which to the tune of about 63% who said that their training institutes were not at all supportive or were somewhat supportive, which actually parallels to what we saw earlier, that is, their training is affected. So institutes which are not supportive of postgraduate students have resulted in hampering of training quality. During this period, of course, they had no other choice. As far as the employees are concerned, the question asked was, if you're an employee, is your employer supportive of you during COVID-19 times? Majority of them responded saying that they were either considerably supportive or completely supportive. So this is a very good response, indicating that about 73% of employed ophthalmologists were considerably or completely supported by their employers. Has your income been affected during the lockdown? Obviously, yes. About 40% of ophthalmologists said that their income was down by 75 to 100%, and 50 to 75%, another 10%. And 35% said that their income was not affected at all. These were mainly salaried employees or pensioners. What about the monthly living expenses? Are you able to meet that? Majority at this point in time are able to meet it, but a minority of them, about 30%, are not able to meet it adequately. They are finding it difficult to meet the monthly expenses at this point in time. What about if the lockdown extends to 3 months or 6 months more? Are they able to have enough cash reserve so that they can at least meet their monthly expenses? About 37% are able to have a deep, about 10% are able to have a deep pocket to be able to meet their expenses for over a year. But others, about 50 to 60%, are not able to meet it beyond 3 months or 6 months. So that is the kind of liquidity they have personally. And are they worried about post-COVID situation? Majority of them, about 90% of them, are worried significantly or considerably. 10% are not worried. And what is the state of mind? We use two questionnaires. One is PHQ-9, which assesses the level of depression. It has 9 questions and which can be graded. We also use the modified Warwick-Edinburgh mental well-being scale. And according to that, there was moderately severe or severe depression in 22% of individuals who responded, which is much higher than that of general population. It's about 10% in general population, having adjusted for age and the professional level of training. This is 22% at this point in time. This is in the last 2 weeks. We did not go for a long-term depression assessment. Very important was the suicidal thought. 91% were absolutely okay, but 6% experienced very severe suicidal thoughts once or twice a week in the last 2 weeks. 3 to 4 times a week, 2%, and these were really on the brink. 1% of them are experiencing very significant amount of suicidal thoughts every day. So these obviously need some help. In fact, all these 9% of these individuals will need some sort of help at this point in time. So what are the bad things about the survey? Training was affected in about 2/3 of situations. Income, more than 50% was affected in more than half the individuals, for more than half the individuals. About 3/4 of them were very worried about the future. 22% are significantly depressed. 9% are having suicidal thoughts, and 1% are really on the brink. But what is good about the whole thing is that employers are supporting in about 73% of situations, and training, obviously it's not possible, but still about 37% of the training institutes are very supportive of their postgraduate students and fellows. So what we now have to do is to reach out, and we are trying to form a small online triad system with selective counseling via small group, including like-minded ophthalmologists, clinical psychologists, and counselors, so that these people who are on the brink and who are very severely depressed can be helped. Thank you.
Yes, Santosh. Nepal?
Yeah.
Yeah, no, I think it's a good survey to know what's happening with our ophthalmologists. I think 1950, the last part is very disturbing about suicidal thoughts and depression. And I think definitely one of the things which Maipal, you asked me to speak is how do we keep yourself entertained? One is, as I think many WhatsApp groups are circulating, and I think one of the things is to have a discipline. Like me, I have now dressed up for this webinar, and I think you have to take pride in attending a seminar as though you're attending a regular conference, and you may choose how many hours you want to attend a webinar. There's in one of the DOS groups I saw, there are timetable is looking more than from morning 7 a.m. to night you have. So you don't have to attend every webinar because obviously you will not concentrate. So I think this is for the people with depression. I think one is to talk to your, either if you're employed, talk to your employer, and if if you're owner, talk to some friends in similar situation, and you talk to your own country or to the rest of the world, which is what I do, because I think that when the things are going on, and one important thing I've done is I've stopped watching television, and last 4 days I've not seen television. Either whatever I want, I see it in the YouTube, and I think you can choose what will stimulate you, what will make you happy, and something like how will you get endorphin. One is I love dance, and I think I remembered my dance practice where some of my friends could not come for a wedding in Chandigarh a few years back. So I think 14 of us were a part of the dance for a one song, 5-minute song, and I think 10 people from Mumbai and 2 from US and 2 from another country. We all did it in that time using the Skype. So the music was going on, and then it was even a partner dance. We had a acting. So I think you can do if you like dance, and same thing with music. And I think you have to spend your time and also spend time with your family, so that you don't all the time think about. And I like the slide which Dr. Shashank Joshi presents every time. It's not called lockdown. We take it as a retreat for your health, and then social distancing. He says call it a physical distancing. So I think the terminology is also the word lockdown.
Can I?
Yes.
You see, all the verbosity is okay, but my question is, with so much depression and suicidal, what is AIOS concretely thinking about it? That is the issue, rather than.
I actually suggested to Maipal that we should have a session with psychologists and psychiatrists, and then there should be because nobody would like to talk on the webinar, but I think they can have a person like Santosh concluded that AIOS can make a arrangement for online consultation. I think I am already working without realizing from March first week with a clinical psychologist who is now also my content writer. That's why we did a public webinar with a psychologist. And I think we have to do one as a general thing of how to motivate people. And at the same time, individual doctors, I think if we can identify them and they can be talked confidentially by the clinical psychologist. Sometimes they may not even call the psychologist. So I think we have to make compare the fit between them.
More than 90% satisfaction, which has been expressed by us members in the leadership regarding this survey, regarding various activities which this current team is doing. More than 90% satisfaction is a very good point. The use of telemedicine, I agree with you, but telemedicine will increase only if somebody guides them how to use it, because majority of people are using just WhatsApp or emails or such things, but they do not know how to charge, how to issue receipts. So here is where I would wish that leadership provides a role, that how to establish a platform in charging, because if you keep them busy, all these points what Santosh said negative can be taken care of.
Yeah, Dr. Lalit, there was an entire webinar that was done on teleophthalmology. It's available on Facebook as also.
I think, sir, I think
that again, Mahipal does not tell the comprehensive member how to do that.
So I think
you see, question is advising is okay. Advising is okay, but how to practically do it is not an issue.
So we can have a hands-on kind of a session on the web itself.
That is important.
Yeah, to actually tell them how to do it.
Today's topic of mental status, that will take time. Whatever you teach the doctors to do the charging, I know it's important. That will do go on. I think everybody is struggling how to do it, because that's what we discussed that day also with Maipal.
So that is why Natti, I'm telling that hats off to Maipal, Namrata and Rajesh who have conceived all these things. But I would want them to go one step further, that practically please, as Namrata was just now mentioning, practically please tell the members.
Yes.
So we'll have something like a web
done to motivate them apart from the.
So we'll have something like a web workshop where we can, demonstrate also how practically these things will be done.
Excellent.
Yeah, Natarajan, do you have something more to say?
No, I only wanted to say that we all have to keep ourselves busy. If the negative thoughts come, I think they should immediately call the closest friend who should motivate. Apart from them, talk about going to the counselor.
Yeah, thank you very much, Dr. Santosh. I think you can put out the group that you are trying, the support group that you are going to make. I think you could put it out, and the AIOS can circulate that in case people need support, we'll do that.
Sure, sir. About telemedicine, I had a suggestion.
Yes.
There are many commercial companies which actually can do this. And if AIOS could organize a telemedicine platform for ophthalmologists, that will be useful. That will be a very uniform kind of a system where you can build in charging, you can build in online consultation, video-based consultation. That will be very useful. So instead of going to different vendors and us exploring the possibility of having telemedicine, if AIOS were to have a group negotiation and then.
So I think we've already talked to a couple of vendors, and we will further talk to them and then negotiate and come out with a proposition at the AIOS website. I think we'll work it out in the coming week.
Thank you. I think let's go on to there are two more segments that are there, and then we'll open up for questions. So the segments that are there are basically, one is to keeping, the financial aspects, and that is how do you keep yourself financially afloat, and this will be talked about salaries, variables, etc. Dr. Ramamurthy, Dr. Ajay Arora, Arup, Shri Ganesh, and Dr. Paul. And then we have the next segment, which is what are the SOPs for restarting the practice. Preetham will be there, Dr. Chitra, Partha, and Chaitra. So let's start with this, that is how to keep financially afloat. We have the first speaker, Dr. Ramamurthy, to please talk about it.
Hello, am I audible?
Yes, very well.
Okay. I think one thing which came across very clearly is that these are difficult times. I have no slides. This talk is right from the heart. And every practice is going to be impacted quite severely, irrespective of the size, whether it's a single practitioner or a large chain of hospitals. And the worst part is that there's not going to be a sudden change from black to white. That is just because we start practicing on May 3rd. Everything is not going to be business as usual. There are going to be various shades of gray for quite some time. And the length of this period is something which is quite unpredictable. I think the only thing I can say is that if you're going to pass through hell, you have no other choice but to just keep going. So obviously, cost-cutting measures, finance is one of the most important aspects that each and every one has to consider. I think cost-cutting measures have to be in place. Already there was some discussion about this force majeure clause. We are not going to be paying in the rentals. I've already sent emails to wherever I was a lessee, and most of the lessors have agreed to this. EMIs need not be paid. Extension of CMC, AMC is another thing which has been agreed upon by most major companies, and they have acted affirmatively towards this. But when it comes to how we are going to take care of employees, I think this is when your sense of leadership comes in. By leadership, I don't mean large chain of hospitals, but even if you're a single practitioner, employing 3 or 4 people, you have to lead your team. You have to consider your team as your extended family, and your leadership capability has to be demonstrated adequately at this point of time. And basically, in this case, it's not a legal issue, even though our lawyer did not give a very right response. I believe there is no legal binding on us to pay our employees when they are not working. It is just a request. But at the same time, what we have to consider it is from a moral standpoint. As far as I am concerned, what I'm going to be doing, and what maybe some of you can follow this, my employees who are being paid less than 30,000 rupees a month, we are going to pay them in full. Because for them, it's a question of basic sustenance. It's a question of their school fees, the rental, the food, etc. And in case, obviously, when we go forward, when it comes to leave encashment, the yearly bonus, yearly appraisals, etc., these things have to be put on hold and some kind of a compromise has to be made. But this basic level of employees, I believe it's our responsibility to see to it that the complete payment is done. And those are in a higher salary bracket. The formula that we have worked out is that it is 30,000 plus 50% of whatever is above that. That is, if an employee is getting paid 1 lakh, is 30,000 plus half of 70,000, that's 35,000, that is 65,000, that's going to be paid to them. When it comes to the level of consultants who form the framework of what we are doing, it's extremely important that we support them adequately also. At the junior consultant level, when their pay scale is less than 2 lakhs, we have planned to pay them completely, whatever they are holding on. Of course, if this stretches on for 4 months, 6 months, 8 months, we might have to rethink about it. But assuming it's going to be for another month or two, is what we'll do. And the senior consultant levels, many of them also have a incentive-based payment. Obviously, incentives are not going to be paid, but we'll pay them a basic sustenance salary of 2 lakhs or so. And we would review this at the end of March 2021 to see how well we have done. We obviously have the numbers for March 2020. And if as a group we have performed well, it's the benefits will be passed on to them. I think at this point of time, one owner cannot conquer this disease or this problem alone. It's extremely important that we do it together as a team. And at this point, it's extremely important that we support them adequately, we keep them motivated. That's how we'll come out as winners against this terrible virus. 2 points just before I conclude. Just now I heard the summary of the results of the AIOS survey. 2 points which struck me was 9% of our ophthalmologists are extremely depressed. They even have suicidal thoughts. And mind you, this is among ophthalmologists. If you come to basic level staff who are not sure about where this next meal is going to come from, this is going to be much higher. And I think we have to keep that in mind whenever we deal with our employees. And secondly, the good part is that 73% of employees considered they are being adequately taken care of, which is kudos to the entire ophthalmic community, the AIOS. And I think we should continue to perform in such a manner, and we stick together, take care of our people working for us. We are ultimately going to win. Our patients have not gone away anywhere. It's just a matter of time. Nobody else is practicing. Whatever we are doing, the patients have to come back to us. It's only a question of when we are going to start performing as usual. It's not a question of if we are going to perform. That's my submission. Thank you.
Thank you very much, Dr. Ramamurthy, for your thought process. Who is next? Partha? No, sorry. Who was next?
I'm sharing, sir.
Yeah, okay. Ajay, yeah, sure. Go ahead.
So am I visible?
Fine, you just continue. Everything is
there. So I am talking as an individual practitioner where there are 2 doctors, me and my wife, and we have a new setup. So as we have heard, we are entering uncharted waters. The curve may flatten, but the corona will keep rearing its head. We cannot compromise on quality. So what we have to do is good practice, tighten our belts, and better financial management. So what are the problems at hand? Cash flow crunch. There will be no work during lockdown. There's reduced volume for next 6 months. There are increased expenses. These are all the anti-COVID measures. There's money stuck in the panels. And since, as Dr. Ramamurthy said, the whole team is my extended family, so it's all emotion driven. We have to maintain high quality with limited resources. And this is the new normal which you're going to have. So we have to innovate. So there's a reduced cash flow. Patients will prioritize. They will avoid premium IOLs. They will avoid refractive surgery, but they will go for emergency procedures. As Dr. V said, a blind person is a mouth with no food. So we should not buy new equipment unless and until it is mandatory and we have adequate cash flow. We have to take care of the extended family, maintain their health, get to know them, how they are handling the crisis, and accordingly take the measures. We have to have robust anti-COVID measures, hand washing policies, and various other anti-COVID measures. Whatever we do, it should be transparent, clear-cut policies which should come from top to bottom, and we should do some organization belt tightening, which I'll just show you. So what is important in our practice today is a pure cataract-based practice may not survive as well as a practice which is pan-ophthalmology, which means cataract, retina, glaucoma, trauma, and the other specialties. We have to have innovations. Therefore, we must ensure that we categorize all areas of our clinic, from the OPD reception to the optometrist to the consultant, as to what all PPE measures we will adopt which are safe and as per policies. We should reduce our consumable costs. Like for us, it is just an example, the Aurora needle trocar cannula system. We have to support each and every personnel within our organization, like the guard here, and everybody is provided with a face shields and a mask. And this is a small little video which says that you have to do this jugaad.
What I've done is, which I normally do, is to put that face tape here so that my glasses won't get fogged. But with the lockdown, the people have masks, also there, the sides are open. So what I've done is tape here, tape below, make sure that it's completely closed. How do I check it? So I put my fingers here and I blow. And I check for any leakage of air. There is no leakage of air. When I suck it, there is nothing coming in from the sides. That means I know that this is completely airtight. So this would work as efficiently as an N95.
So these are some of the measures which we have to do. We have to encourage patients to do cash payments. AIOS has to push for TPS and panel releases of payment. I do not know if we have to increase our rates, because patients have also problem. They will actually be asking for discounts. We have to give charity to the vulnerable patients. We should club surgery so that we reduce our costs, and we have to adopt good anti-COVID measures. So regarding the rent, as everybody said it, we have to renegotiate our agreements. We have to use our electricity judiciously. There have to be moratorium on AMCs, and all these things have to be talked about. I'll come to what we are thinking in terms of staff. We have paid them completely for March. Regarding April, the center was closed, but we got a notice from the CM. So we opened it on 8th with reduced timing for a few hours. All those people who are absentees, we will give them a substantial disaster allowance whether they come or not. So those people who come for the first 7 days of not coming, we will calculate the disaster allowance, and rest of the people will get most of the salary. That is almost about 80% of the salary. And I agree with Dr. Ramamurthy that we have to understand their situation, and maybe sometimes we have to personalize. We will have to judicially use this leave, extend their working hours, and I do not know if we have to cut the salary, but this may be graded beyond a particular amount. The vulnerable people within our extended family will not have a salary cut. So the take-home message is COVID is not a dream. I get up in the morning and sometimes I think, is it really COVID happening? But it's real, it's there. We have to fight it. We have to fight it together as a family and as a nation. We have to innovate and make in India solutions. The AIOS has to help us in getting our payments released, reducing the custom duties in future. We have to have quality control. We cherish our customer satisfaction. The patient's flow should be kept with social distancing in mind. Charity begins at home, so take care of your extended family. We must prefer compassion over capitalism. We should retain our trained staff, and we should make sure that some of the staff may not be working some other practices. We should not poach upon any of the staff from any other practice. Smaller centers with lesser overheads may do slightly better. Thank you for your kind attention.
Yeah, we go on to Dr. Arup now. And yeah, Dr. Arup.
Yeah, am I audible?
Yes.
Yeah. Okay. Thank you, Dr. Mahipal, Dr. Namrata, for having me here today. And those of you who know me for quite some time, we started a new hospital about 6 months earlier. It was sort of a...
The audio is...
Oh, I think its connection went off.
It was quite a setback for us, and we decided to discuss with our peers, friends, various advisors, legal advisors, and others. And then we prepared a presentation actually for Kerala Society of Ophthalmic Surgeons. I'm going to present part of that to you. So what I have been asked to talk about the salaries and the variables. How do you manage it? And I'm not going to touch upon the points which have already been covered by Dr. Ramamurthy and Dr. Ajay Arora before me. As regards staff salary, it is a very sensitive matter. But we always believe that human resources are more important than material resources. You cannot find a replacement for a staff who has been with you for more than 2 decades, a staff who has been loyal to you, who has got all the experience. Material losses, they can always be recovered in 3 months' time, 4 months' time, we'll get it back. So our main emphasis has been on the human resources. So from this point of view, we have divided our staff into 3 categories. Those who get less than 25,000 per month, more than 25,000 per month. I think Dr. Ramamurthy's figure was 30,000. So for both the categories, we will not be cutting I would not say the salary cut or something, I'd say salary adjustment. So for the next 3 months, I'm not going to adjust the salary in any way. However, if the lockdown proceeds beyond the 3-month period, then we'll have a discussion with the staff who are drawing more than 25K and find out in what way we can have a mutually agreeable understanding. As regards the payment of EPF, ESI, and Labor Welfare Fund, we paid that for the month of March, and soon we got a advisory from the EPF that for next 3 months, one need not pay the EPF provided these conditions are satisfied. That is, if your firm has less than 100 employees and 90% of these employees draw a salary of less than 15,000. So I think that is not really practical in most of our situations. So we end up paying the EPF, ESI, and Labor Welfare Fund. Now, there is another provision in the EPF for that of taking loan. In case you invoke the force majeure clause and adjust the salary for certain staff members, they can avail of 3 months of their basic plus DA, or a loan of 75% of the total amount of EPF that has been paid, and whichever is less. And those of us who have been doing TDS for the consultants, or those who have been drawing higher salaries, so the TDS is definitely not necessary for the next 3 months. And after 3 months, what are you going to do if there is a prolonged lockdown and the income doesn't really come up? So it's a very difficult decision. So we are not going to retrench any of the staff. And at the same time, I would advise my colleagues who are thinking in these lines must get a legal opinion, because it is a gray area. One really does not know where exactly we are standing today. The Prime Minister's address the other day did not touch upon this issue, but the legal advisor he also did not give us a clear direction. But I think we need to be very open and very, keep our eyes and ears open. But as far as I am concerned, we are not going to retrench any of the staff members. In fact, we have a peculiar situation. We had 3 staff who left, who are on the verge of leaving. We took in 4 staff. So we have 7 staff members now. The 3 staff members who are supposed to leave a job and go to Middle East, they can't go. So they want to join back. And the other 4 staff, they have less than 1 month experience. They are not coming because of the lockdown process. So we have decided to continue with those 7 staff members for at least 3 months till we can arrive at a mutually convenient decision. So this is as regards the salary. And regarding the other financial aspects, see, we took quite a bit of a loan before we started a project, and I'm sure many of you are in the same boat. So we had a discussion with a chartered accountant, with the bank manager, and this discussion happened before, there was, I sort of anticipated this thing happening before the Reserve Bank instructions came. And then we have agreed on a moratorium of 3 months. So according to my chartered accountant, the category of loans which have a low EMI and really short term, I'm paying them off. I've decided not to avail of the moratorium. On the other hand, all the loans with a large EMI and long-term loans, 5 years, 6 years, or 7-year term duration, I am taking advantage of this moratorium, but you must keep in mind that the interest is compounded. So at the end of this lockdown period, either your EMI term is going to go up by a couple of 5 to 6 months, or you have to increase the EMI if you want to keep the term duration the same. Regarding the maintenance issues, and I mean, it's my own building, so I don't have to give rentals. But we have not got any waiver from the Electricity Department, Kerala Society of Kerala State Electricity Board. Security agency has to be paid. Image, the waste disposal, which is so beautifully done, has to be paid at all costs. We cannot have a situation where the waste is not collected from the center. And we had certain expansion plans and purchasing some more equipment in the next 1 or 2 months' time that had to be shelved. And as regards the AMC and CMC, there are 2 categories of equipment, medical equipment. All of us have known the equipment suppliers for a long period of time. So we have a good understanding with them, and they have given us an extension of 3 months of AMC or CMC. On the other hand, as regards the non-medical equipment, like the HVAC or the air handling units, UPS, lift, generators, since ours is a new establishment, so we have a 2 or 3 years warranty that is already covering it. So at this point, I'm not really negotiating with them for an additional 3 months because I have a 2 or 3 years of leverage with them. But here you must understand that the suppliers of the generators and the service, the vendors and the service providers are not the same. And we need to build a good rapport. It has taught me that we need to build a very good rapport with the service providers, not only the vendors, so that when the need arises for this similar situation and how to circumvent those situations, we are on a better footing. So we have to have a proper discussion with the vendor and maintain copies of the written communication to prevent further controversies in the future. So friends, there are challenging times ahead, but I'm sure we shall overcome in due course of time. Thank you.
Thank you very much, Dr. Arup. You just kept quiet about the consultant's salary. Is it because you and your wife are the only consultants?
I mean, this is a sensitive issue. I didn't want to talk about it, and Dr. Ramamurthy has already spoken about his plans, and it has to be individualized. And I mean, I don't think one treatment will fit all situations is not going to work out in these situations. It depends upon the rapport that we have with our senior consultants or junior consultants.
Okay. So there is some thought process which you feel is individualistic for your perspective for consultant.
Yeah, it depends upon the level of communication and relationship that we enjoy.
Yeah, Dr. Shri Ganesh, please.
Good evening, dear friends, and thank you, Maipal, for inviting me. And I would just be talking about what we are going to do. We have 8 centers, about 300 staff, and about 40 doctors. And let me just pull up my presentation. So how do we financially stay afloat during the COVID times? This is always a challenge. For us, our profits for the last year were not very high. They were single digit, and we have very limited resources. So now we'll have to see how we are going to manage this resource, considering that the whole of April we have not worked, and also 1 week in March, and we don't know how May is going to pan out. So we had a discussion of the top management, and then took some decisions on how we can manage. And most of my consultants and staff have agreed for this, so I'm very thankful to them because these are trying times. So for employees whose salaries are less than 25,000, we have not cut for April. Of course, for March, we have made the full payments for everybody. And between 25 to 1 lakh, 25,000 plus 50% of the amount exceeding 25,000. And 1 to 2 lakhs, we are paying out 50,000 plus 30% of the amount exceeding 50,000. And 2 to 3 lakhs, 75,000 plus 20% of the amount exceeding this. And the maximum payout, we have limited it to 1.25 lakhs for the employees. For residents and fellows, we are making full payments for those who have worked. Some of them A few of them have gone home and they are completely absent. So for them, we are going to cut the stipend. And for consultants, basically, we are looking at a 30% cut for those who are earning up to 1.2 lakhs, and 40% for those up to 2 lakhs, and 50% for those up to 3 lakhs. And the maximum payout also, we are kind of cutting it to 1.3 lakhs. Leadership by example is something that I believe in. So the founder directors, me and my wife, are taking a full salary pay cut, and also we own some of the buildings, so a complete rental cut. So this is going to save some money for the company. And also the three directors who are there have agreed to take a full pay cut, so that we have to tighten our belts first before we can actually look at our consultants and employees chipping in. So strategies after May are also going to be very important. We have right now negotiated the rentals to 50%. The rentals, the landowners did not agree for a waiver for April. So 50% payouts for the properties for April. And then we are looking at negotiating for a 20% cut thereafter. And from May, we plan to have extended working hours from 9 a.m. to 9 p.m., including Sundays, so that we are able to kind of reduce the crowding in the clinics and then stagger patient appointments. And we will have split hours for consultants and staff. We'll decide the salaries for May onwards depending upon the revenue generated, and we may implement some pay cuts accordingly. If the revenue is good, then we may not, but again, it depends. And from the financial advisors, it may take up to the fourth quarter. So this is something we have to look at, and I've already spoken to my team about that. Retrenchment and non-performers, basically there are two options. Either we can lay them off, or we can watch for a couple of months and see how the finances are going. We will avoid laying off initially, and we will hold out as far as possible. Once it becomes tight, then we will have to look at it, because there is no other options. We will have to keep the performers and then let go of the non-performers. And also we can look at multitasking for staff, so staff can take on more responsibilities. We'll also have to look at reducing utility bills. We are going to switch off all the ACs except in the OTs, and then just have fans and keep the doors open. So these are small things which we can look at saving money. And we are going to avoid all new investment in equipment. And of course, the CMCs and AMCs extended by 3 months. We'll have to look at the non-ophthalmic equipment also, like lifts and generator. Coming to the leave structure, we have decided there will be no encashment of earned leaves, and they have to be utilized over the year. So that will save some money for the company. And coming to conferences for the consultants, no conference leaves for this year, and only on special permission. If they have papers or courses, then on a case-to-case basis, it will be decided. So these are some of the measures that we have looked at, but we may keep changing as time goes by and we see how things are panning out. So thank you very much. And this is just what we have decided.
So, thank you, Dr. Sri Ganesh, for your presentation. And I think now it is the time for the next presentation, Dr.
Paul.
Paul.
Am I audible?
Yes.
Thank you. Good evening. Namaskar from Kolkata. My entire perception will be different. Something is not in my hand. Just like Corona control, we don't know. We have to follow what the government rules are there. Mainly, social distancing, health and hygiene, mask policies, PPEs, etc. Let's talk on something positive, that what we can do to come out of it. So if I go on discussing our financial policies for the lockdown, let me be very honest with you. Once the lockdown was going to be declared, we made a 4-month plan. 4th plan means March, April, May, June, means first quarter of the year. after the PM's lecture on this the last day before yesterday, we made a plan for the second quarter of the year. Means now we are ready for the 6 months. So what we did is basically, yes, we have to keep in mind that we can generate some of the formulas. Most of them already had been discussed. But what is important in case of service industry, that had to be customized. Now, in our policy, what we have found that if it is closed for lockdown for the 6 months time even, why I'm telling it 6 months, suppose the first 3 months we don't have any income, next 3 months maybe intermittent lockdown, means some kind of partial lockdown. We are talking to different groups. Even today we are hearing this financial analysis, the operational analysis. So we are not expecting some kind of business in very high. So cut down is somewhere necessary, but what is important into it, that had to keep in mind something, statutory rules we cannot break. This had to be kept in mind. Had to be mind that those who are having the less salary, whether it is a consultant or whether it is a staff, we should not touch them. Rather, it is a difficult time, therefore with us for a very long time. So we have to customize everyone. So we sent one mail, SMS and call to everyone that for this first 4 months, what is your basic necessity? And definitely cross subsidy from the upper range. I can declare you what we did for the first quarter and second quarter, this 6 months, and the month of March, this 7 months, with the availability of the 60% of what was our expenditure. The people's 99% of the people are still happy. Now, somebody may ask you from where you have generated this fund. Let me be very honest, we had worked up to 15th of March. There is definitely a profit generated for the entire 365 days minus 15 days. And suppose it is for the, some corporate group where they can go for maximum credit limit from the bank. Now, for the lockdown, something what we are doing, this is emergency OPD, emergency diagnostic, emergency IPD. Definitely one point is there, this is the separate trade eye clinic. E-consultancy, probably I'll spare some 1 or 2 minutes. From our understanding, we took it that we are very sure once the lockdown is over and once it gets even normal, we may not get back return of our normal customer, means those who was with us. So some form of new acquirement should be there somewhere or other. So we started e-consultancy. This is not teleconsultancy, because what I have presumed in last what is called 5 years plan, the government of India spent a lot of money in case of this teleophthalmology, but somehow or other, you all know what is the difficulties. So this is something. And from the day one, when the lockdown was declared, we are not sitting idle. What we did, what is possible for implementing these policies, new policies will be come up when the lockdown is over. We have started it, and training of the post-lockdown policies. I am just mere sharing you with one video. Fine. In the post-lockdown period, I know whenever I have an account, I can manage it well. Manage these 4 policies of social distancing, health and hygiene, the mask policy, everything. So the appointment we will give, ensure that whatever maximum possible should come through appointment. I do appreciate that the main factor, while the people won't be coming, this is one of the COVID-19, that I may get infected or I may transmit. Another factor is definitely, less cash flow. So we have to take care of it. Now, if I have to manage these patients of the existing patient, everybody has some extra space. That can be, somebody told about extra days, somebody told about extra manpower, extra timings, even from early morning to late evening. And we have assured all our entire some 800 families are with us that if I get an increase of 10%, so along with this 60%, 10% means 70% will go to you. If it is happening in the month of April, very happy. If it happens 100% in the month of May, we are very happy, then we can go for it. Physical remodeling, something really we can do it within the lockdown period. We did. Rest, we are very ready. Once the lockdown is over, definitely we'll be doing. But giving importance to the SOP, all the SOP must be ready with what we should do, and the training must be completed and all documentation must be ready. Marketing, this is one of the important part, that how it is really safe in terms of disease transmission and acquiring the new patient. So with these few words, again, I thank you, all the AIOS official, and really I thank my AIOS member. Thank you.
Thank you very much, Dr. Ratish Paul. We'll come to the last part and then we'll have quick fire questions that have come up. So let's go on to the next. That means if you have to restart, what would be the SOPs there? And I think the first person to speak would be Dr. Preetham, right? You are muted.
Yes. Yeah. Shall I share my screen, sir?
Yeah.
So the first aspect of the SOPs in the aftermath of COVID-19.
Can you
hear me?
take it on slideshow?
Yeah. That's fine?
Yeah, perfect.
Yeah. So the first aspect which I'm going to deal with is the triage and the appointments in the aftermath of COVID-19. Now, the appointment triage, so far we have dealt with only triage when the patient comes and, we take a history and see the findings. But I think now we'll have to get used to the concept of appointment triage. That means even, triaging the patient even before you've seen the patient. That is, while giving the appointment itself, you vet all the aspects of that particular patient. And for that, this is a very simple grading system. This is something which we have started at Hinduja Hospital. Dr. Nayak sir will be aware about this also. Now, this has simply 3 questions which can be asked even by your secretary or the person who's giving the appointments to the patient. There is a travel within the last 14 days. And then, depending on the answer, you grade it as 2, 4. If it's domestic travel, international travel is 8 points. The second question will be symptoms in the last 14 days. So this is pretty straightforward. No symptoms is 0. And if the patient has upper respiratory tract symptoms and cough, fever, it's 10. And the last is the contact of the patient with, a COVID positive patient in the vicinity. So here we have again 0, 6, and 8. And then you calculate the scores and you come up with a total score. And essentially you look at a score less than 6 and more than 6. So less than 6, it will classify as low risk, and more than 6, it will classify as high risk. And then, you have the signature of the person who has taken this questions from the patient, writes the name over there. And then if it's less than 6, the management is as a general patient, of course, but with all standard universal precautions. But if it's more than 6, then, your red alarm goes up, and then the patient goes in through, the entire protocol for COVID. So this particular questionnaire and this criteria are essentially given, come up by the American College of Surgeons and the Royal College of Surgeons. So this is about triaging on phone for the patient. This will have to be looked at in the near future. When it comes to scheduling appointments, someone already mentioned that we will have to stagger our appointments. A lot of us are used to seeing 15, 20 patients in 1 hour, probably, those with high volume patients. But we might have to come down to seeing maybe 4 patients in an hour. So probably give slots at 15-minute intervals. We will have to avoid scheduling in the distant future, because remember one thing, when you take this questionnaire, when your secretary takes this questionnaire, it will have to be immediately before the appointment. If you're going to give an appointment couple of days future, the situation might change. So if you're giving the appointment in a distant future, you might have to triage the patient once again on the phone and make sure that his score is under 6. So that is important. Now we are used to OPD list. Now what I mean by this is we are used to the concept of operation theater list or OT list, where we are involved with our OT list. We very rarely, we give less importance to what our OPD appointments are, really speaking. But now we'll have to get used to the concept of OPD list, where as clinicians, we are taking active interest in seeing, whether the OPD patients and the appointments are triaged or not. We might have to even, get used to the concept of calling geriatric and pediatric patients at separate timings. Probably the big institutions already have separate areas to deal with these patients. They can do that. But when it comes to small setups, they may have to be called at separate timings, because we know the geriatric group is more susceptible to COVID. And lastly, someone did mention that, our OPD hours are going to be long because we are going to see less amount of patients in the same amount of time. So we will have to get used to working long hours, and probably our staff, we will have to divide maybe in 1, 2 or 3 shifts, so that, the staff energy and the ergonomics are also suited to those kind of long OPD hours. Regarding prepping the patient, this is my last slide, actually, second last slide. Now we, just like we prep the patient for an OT, here probably on the phone, our secretaries might have to prep the patient before the appointments. So the patient will have to be told about the longer waiting time. Patients sometimes are used to a certain amount of time in our clinics. Now those patients will have to be told that there will be a longer waiting time. They will have to be told to, take all the precautions like wearing the masks, the patient with the attendant. Otherwise, your resources are going to get depleted if you start providing masks to everyone who's going to enter your clinic, mind you. They have to be told that they may have to give special consent. It's better to tell them on the phone that we will be taking a special consent, probably asking them to write a questionnaire. About attendance, if it's usual routine refraction patients or young patients, probably you might have to tell them don't come with an attendant, and at the most allow one attendant for aged patients and pediatric patients. And one more thing is, if the child is not a patient, is just an attendant, then avoid calling the children. You have to tell them that no children will be allowed as attendants. So these are some of our appointment protocols we'll have to change. And lastly, just a touch up on these 2 points, someone, about telemedicine and teleconsultations. So how do we give appointments for telemedicine and teleconsultation is again a matter of debate we'll have to look into. And in the recent past, we have seen that artificial intelligence has played a big role in diagnostics and in investigative modalities. So probably it is time that we start using AI for scheduling our online appointments. Because at the end of the day, how much can your operator or your secretary who's taking appointments, how much time can she spend really on giving appointments? So probably you might have to use artificial intelligence. So these were some of the aspects of appointment scheduling, which I thought I would like to share. Thank you.
Thank you very much, Dr. Preetham. We go on to the next speaker. Next is, I think, Dr. Chitra.
Chitra, you have to unmute yourself. Admin, please unmute Dr. Chitra.
Can you hear me?
Yes.
So we are all going through the same crisis. And I heard Preetham speak. I really wish I could dress what I'm going to talk differently, but I suppose it's going to be nearly the same. So some of you are allowed to go to sleep. So here I go about the OPD guidelines. Just a minute. Shrey? Just a minute. I think it's not moving to the next slide. So I think I'll just go ahead and talk. Yeah, no, I'll just talk without the slides. So I really don't understand why it's not changing to different slide. So basically, these are some precautions which are very specific to our OPD management. And we need to see how we can be specific about dealing with it. So some of what Preetham had already said, that history taking when the patient comes to your hospital are something which is going to be just about the same, like a detailed history of his travel or coming from a hotspot, and ensuring that they wear a mask and use a hand rub, and being very strict that there should be only one attender or no attendee at all. Once you enter the OPD area, we have to ensure that there's a space seating, and definitely be very particular that there is no crowding at the reception desk, and the receptionist should be on a very active drive to prevent this. Probably if your space allows, you could even have 2 reception areas, and even more so if you have 2 floors where OPD is being seen, you ensure there are 2 reception desks and keep a separate counter for your tele-appointment patients. Again, cash counters should be multiple because that's another area where there could be crowding and we need to deal with it. Of course, we are not presuming at all that we are going to have a crowded OP. It's just that this is our ways for social distancing. And of course, ensure that every staff and doctor wears a reusable N95 mask. As far as the specific clinics are concerned, like if a patient comes in with redness or conjunctivitis, he should be directly sent to the allocated room where the attending doctor is going to be donned in a PPE. And these patients should not be allowed to mingle with the rest and sent off with medications. But when it comes to dealing with the specific subspecialties, these tend to be a larger floor, and there is a delay which are inherent, especially in glaucoma, retina, and pediatric. So a triage would have to be specific to each department with specific receptionists and counselors to deal with each of them. Every effort has to be made to speed up the evaluations. And like, for example, if it's a glaucoma patient, we should take a call that we are not going to be doing a fundus evaluation for a routine patient or a goni or an intraocular pressure unless it's specifically indicated for that particular glaucoma patient. Again, the pediatrics should be quite totally segregated with their specific evaluators. Staggering of appointments, we should insist on appointments for all our patients to what feasible extent. And of course, all of us have walking patients and they do tend to come more in the morning. So we have to stagger our regular appointments to early or late afternoons. We have to send a mass SMS to our entire database and tell our patients that we are going to work on appointment system, keeping the COVID disease in mind, and reviews and appointment patients should be clearly in the afternoon. Again, as all was said, timings of OPD has to be increased to accommodate spacing out of patients, and we should encourage tele consultations, which is going to happen. But again, we have to keep them a different slot, especially when the crowds tend to be temporarily wane off. We have to be very encouraging in our counseling to our patients during the time when they are waiting in the OPD about how hygiene and self-protection, especially at the reception and the waiting areas. We should have a TV display on which specific instructions at different time points would keep coming in, especially the OPD is more at that time. We should ensure that 70% isopropyl alcohol is used for cleaning all instruments, headrest, chin rest, everything which has already been said. And also those frequently touched areas have to be cleaned at regular intervals. Housekeeping cleaning has to be done by the guidelines, and our patients should see them clearly visible when they are sitting in the OPD, because that's quite reassuring to the patients that we are following all the guidelines. And as far as the pre-op workups are concerned in the OPD, we have to closely monitor that we do a very adequate follow-up with all the evaluations, with the physician evaluation in every single case, and a COVID testing is mandatory. And we should ensure that our operated patients are discharged as early as possible the very day, and that has to be ensured. And again, in the opticals and the pharmacies, we should ensure spacing, because that has to be a critical measure. There tends to be crowding there, and keep gently explaining to the patients. And we have to see that the frequent post-op reviews are totally taken care, lessened, and even the review numbers really become down. So essentially, what is most important in our OPD area is to improve the happiness quotient of our patients and ensure a secure feeling for all of them during their time with us. Thank you.
Thank you very much. We quickly go over to Dr. Partha. Partha, just try and avoid some repetitions if there are any.
Yes, sir. So is it visible, sir? Slides?
Yeah.
Right.
Yes.
Okay. So premium non nocere and first do no harm. And in the COVID era, what we have been following, and AIOS has given out recommendations, that is to provide urgent and emergent care only. It has been our duty to provide intervention in the sight-threatening disorders only, and at the same time protecting both patients and ourselves from COVID-19. Now, the SOP for the post-COVID era, and gradually elective procedures will have to be taken up. And however, the COVID-19 situation may be prevailing for a few months and do not know how many months. Therefore, we have to remain vigilant. And at the same time, we have to understand that the dynamic post-COVID era regimes, protocols will be changing. So SOP for the IoT, which cases to take up in the IoT, and we all know that the cash flow for the post-COVID era is going to be an important area, because that's where every institution, every private practitioner is going to come back to his or her own feet. And this is important, how we space out our surgeries, how we take up the surgeries by and by. Initially, all surgeries should be day care. Emergency cases, of course, to given precedence over elective, and the total number to be limited and posted in a very, very staggered manner. This is important both for our patients, for our staff, and for ourselves. With surgeries best to be avoided, any case under GA which can be postponed, maybe more when we have learned and we have a better dynamics, and DCR may be postponed by a month or two if it is possible. Any CAM surgery which is not an emergency needs to be postponed definitely. OT scheduling, pre-operative counseling plays a very, very important part. Just like the OPD, pre-operative OPD counseling is important, the pre-operative counseling is equally or more important. Patient and attendant must be made aware of the current scenario and the risks involved, and the consent that the AIOS has issued must be duly signed and kept safely, hard copies as well as the soft copies. The pre-operative tests to be done. Well, all routine tests to be performed exactly as we have been performing, chest X-ray to rule out active lung infiltrates. And this is something that can be done for all our OT patients. The understanding for a COVID-19 test, feasible for the elective patients for surgery. Is it feasible? What the government is going to play as a rule or regulation and the protocol to be laid down by the state health department is all very, very important. And if possible, a tie-up with a lab, if possible, will definitely increase the safety of the staff and patients alike. However, as I said, health is a state subject and the government protocols need to be followed. The pre-operative precautions to be followed, to the patient to enter with one attendant, and masks, of course, mandatory for the patient and attendant. Patient masks to be changed before the patient enters the OT, and norms of social distancing, of course, to be there. The per-operative precautions to be followed, number of OT staff as minimum as possible, guidelines for OT gowns and protective wear for the OT staff, and these things will definitely be deliberated, and in the coming week we'll give a guideline from the AIOS. Quick and safe surgery to be performed by seniors preferably, and all universal precautions is to be taken. Topical anesthesia over local anesthesia is better. No two patients to be handled together, which is important. And the protocol-based disinfection of the OT to be done after each surgical procedure. Stop positive ventilation in the theater during procedure or at least 20 minutes after the patient has left, and smoke evacuation after the diathermy. Aerosol generating procedures such as intubation, extubation, bag masking, electrocautery to be done by the anesthetist. And at this point of time, possibly PPE is important. A word about HCQS prophylaxis. The ICMR has advised oral hydroxychloroquine 400 milligram BD on day 1, followed by 400 milligram OD weekly for 7 weeks. Now that is an individual discretion, and again, what the government guidelines go. Important to remember that no suspect or confirmed cases to be scheduled for surgery. Let us refer it to facility with ICU, and mask mandatory for patients undergoing major or minor surgeries. And these are absolutely extraordinary times and calls for extraordinary measures. Thank you, Dr. Mayapal sir, Namrata, and the whole team responsible for these the wonderful webinar.
Thank you very much, Dr. Partha. We go on to the last speaker and then we are open for questions. Dr. Chaitra from NN is going to talk about the SOP specifically for retina surgeries.
Good evening, everybody. I'm basically going to be talking about the procedures that we do in the OPD on a regular basis. It could be anterior and posterior segment, contact and non-contact, and what precautions we need to take as doctors when we are doing these investigations. So from that point of view, the first and foremost would be that we ourselves wear the masks, wear the goggles and the shields whenever it is feasible for whichever of the procedures. PPE is not mandatory unless I think the patient is COVID positive as of now. We also have a shortage of the PPEs. Second point that I would like to come to is the multi-dose eye drops that we use in our OPD, whether it could be dilating drops or the topical anesthesia. I think we're all using them in our OPD. So how do we go about instilling these drops is have a designated staff to do it. And ideally, like always, do not touch the lashes or the ocular surface. Each and every post every patient, the concerned personnel should disinfect the hands after every patient so that when you touch the next patient, the virus is not carried forward if there is one. Third point being that there should be no aerosol generating procedures being done unless absolutely required. These could be the air puff, it could be the syringing, NCT, whatever else that we're doing in our OPD which can generate aerosols should be completely avoided. I think we all use slit lamps and we use our indirect ophthalmoscope. So we should be using a breath shield for that. Existing small one is not adequate. We need to make one at least of A4 size. And once that is installed, I think it will be easy. And one should remember that the patient side needs to be cleaned frequently because every time an aerosol is generated, again, that is going to become unsterile. We need to put it in between the oculars and the patient, and then it's relatively safe. The same can also be used for the LIO, which is the preferable method for laser rather than the slit lamp delivery. Coming to tonometry, the tip and the housing can come into contact with the patients when we're checking the IOP. Again, try to use disposable tips or use 70% alcohol to sterilize in between. Indirect and slit lamp, comparatively, indirect is better, again, with the shield. A lot of videos where it shows us how to put these shields. And LIO delivery is preferable. Avoid contact procedures whenever possible. Most of us have wide field imaging. If possible, let's just make do with imaging and again use barriers for all these investigations. So these are some of the points in the OPD when we're doing procedures. And I think it kind of gives an overview of the SOPs once we start back post-lockdown. Thank you.
Thank you very much, all these speakers. Now we can take the questions. I think Dr. Namrata.
Yes, sir. I'll quickly do. These are just one-liners. So they want to know that a lot of senior residents and senior residents from my center as well who want to know that they're going to finish their fellowship or senior residency. Should they be joining a corporate hospital because none will take them now, or should they be starting on their own?
So,
Dr. Maipal, sir, what is your opinion on this?
So the basic question that majority of the people have asked that should they take the risk just now to start their own practice, I would personally be of the opinion that it is better to wait and watch because I really don't know how long this depression is going to last as regards the economics. So it may be a difficult thing. So there's no problem. They're young. They could wait out for some time and basically then think of starting their own and investing because investment just now may be a little tricky in the present situation.
So that's for Karan. I hope you're listening. You can tell all your young ophthalmologists. Second question is, should we outsource the opticals and the pharmacy that we already have in our areas, or should we allow them to continue? Anybody can take this question. Dr. Paul, yes. Dr. Paul, can you unmute yourself? Yes.
This is an era probably we need to generate more fund. So the opticals will be one arena where we can generate fund which can supplement the hospital. Pharmacy is another arena which really we can generate some fund and really we can do it. In fact, we should start off something if we have some group hospitals or group having large number of like items like cap, masks, blades, the gloves. These are the common items which can save some money and can generate some extra money. This is my take.
There's another question which is very interesting. It says, should we start advertising for emergency conditions of eye surgeries? Should we start saying if you have a fresh RD, please show, or if you have these things, please show? The word is advertising.
It's not that. Basically, what I do, can I answer or somebody
Yes,
else?
yes, please, please, anybody.
So understanding my process is this, what I understand, first of all, I have some 20 lakhs people in the last 10 years, the database is with me. So first I ensure in case of your emergency, I am there. And second, as an eye care organization in the East, I ensure with all kinds of social marketing that in case of your emergency, I am there. So that ensured me my viability of when the lockdown is over, that point should be taken care of very positively.
I think what Dr. Karan said is, and what Dr. Ritesh Paul is also saying is that you should try to keep hold of the patients that are yours. You need to engage with them, and you need to tell them that if in case there is any emergency, you need to be aware of it, and we are open to take care of your emergencies. I think going out at the present moment is not going to be very productive.
And should people start merging into group practice to decrease the revenues at this point in time?
Decrease the costs, not the revenues.
The cost.
Partha?
I'll take this question, sir. I think the group practice holds a lot of promise from both sectors, from individual practitioners who have been in practice for maybe 10 years or 15 years, and definitely for the juniors who are just thinking about a solo practice. So a group practice minimizes costs at all levels, actually helps the importance of time and space, which are all covered and shared, and the equipment is all shared, and the costs are definitely shared. So group practice is definitely the way to go for practitioners who have not yet ventured into group practice or who are thinking of contemplating practice by themselves.
So basically what you are trying to say is that there should be sharing of the capital expense that is there, whether it be in a group or whether it be from a institutional level or whatever it is. I think that's what the young people were asking. This may not be the right time to kind of make investments. One question for everybody, Namrata, maybe you can reply on the group on WhatsApp. How long do you think it will take for us to come back to within 90% of what we were doing? Just answer 6 months, 6 months to 12 months, and more than 12 months.
So Rajesh, can you keep a track of that?
So please reply on the WhatsApp group. How long do you think it will take for us to come back to about 90% of what we were doing? Less than 6 months, 6 months to 12 months, and more than 12 months. This is for the panelists. Yeah, Namrata, you can go ahead.
So now, sir, there's another question for each one of you. Only me and Rajesh are exempted from it. And that is, are you going to increase your consultation fees, decrease it, or will it remain the same? Sir, we'll start from you. Dr. Mahipal, sir, and then Dr. Ramamurthy.
I think it will remain the same or it may decrease.
Dr. Ramamurthy?
So Mahipal is not increasing, I will definitely not increase.
I think he's already increased his fees.
No, these are times when patients are going to be hard pressed for cash, and we.
I think no, I know. I was thinking of, but I think seeing the lockdown, no. And I've actually, we are more into teleconsultation now, and I think all doctors are doing so. I think
Dr. Nayak, sir.
No,
I think you have to show compassion.
No question of increase in the.
No question of increase. No question.
So everybody, I think, is on the same page that we are not going to increase. Dr. Sri Ganesh, you said that we have to spend more now on masks and disposables and PPE. Have you increased your fees, or is it just the same?
We were thinking of increasing, but what I'm thinking is now that patients who don't come in with a mask, then we'll be selling them masks, because it's mandatory that they wear a mask and come into the practice.
No, let me clarify here in the sense that, we definitely intend charging a surcharge of 50 rupees per patient, not just for consultation, but even those patients who are coming for review. And these are for every walk-in patient. This is to cover our costs of masks, not just for the patient, but for the attendant and all the precautions that we are taking.
Yeah, so basically,
can I just have a word on this?
Actually, sell the mask outside, and they can buy it from this thing. So it's not that you are charging 50 rupees extra. It might be they come with their own mask, or in case they haven't, they can take a mask and kind of come in.
Can I just have a word on this? So what we have decided, this is Arup here. What we have decided is we'll have a kiosk selling masks. So patients who do not come to the clinic with the masks on, we'll send them a mask and there'll be 50% extra for the registration. Rest of the charges are going to be the same.
Okay.
So there is another question which says that any scope for eye centers which are specialized in COVID patient care. I think nobody would agree on this. Then
can we have some more responses on the question that Maypaz had posted?
So there's another question which says that suppose in my district there are no hotspots and my district is okay, there are no cases, but in the adjacent district there are. Should I continue to operate or should I not start surgeries because my district is kind of not free from the COVID?
So my personal take is that the government is going to come out with the green, yellow and red zones. So I think you have to wait for that. And in case you are in a green zone, then possibly you should restart surgeries with the SOPs that have been laid out by the earlier speakers. Rajesh, you have got
my HR had sent me some cuttings now from today's newspaper. Also, the government is setting up grievance cells, the labor ministry. So those who have received a pay cut or cut in wages, they can complain to the grievance cell, and they said that they will take action against the organization. So this is something new that has come up. So whether how this is going to impact us legally, whether they can enforce us to make full payment of wages is something that I don't know.
Just read that must be for a workman.
Yes.
Yeah, so workman is somebody who's at the who does not have a managerial authority. So I think majority of the speakers have said that for the lower 25,000, 50,000, there should be no cuts. But
no, it's for all employees. For all employees.
Okay, is it for Karnataka?
No, yeah, that's Karnataka. Come from Karnataka State Society.
Karnataka. Yeah. Karnataka.
Okay.
But I think it's not applicable to all classes of people, not maybe somebody like a consultant level, it may not be applicable. Yeah. But at a basic level, less than 30,000, it's more a workman act rather than applicable all across the board.
Dr. Ratish?
Yeah, I have a question to all the panelists. When we talk about the intermittent lockdown, means supposing there are so many variations, combinations that hot spot, yellow spot, green spot, etc. Particularly lifting of ban from everything, partially from the agri sector. Today they released from IT sector, some industry. But if a scenario comes like this, that there is a complete closure and there is a complete, maybe partial open, and then we are suspecting something of a complete closure. So for the elective surgery, because eye care mainly deals with two primary component. One was the cataract, another is the presbyopic, correction. So what it should be the minimum time that if there is a gap of 7 days, 15 days, or 3 weeks, when do you suggest to start the surgery? Because if we foresee something that after 1 week or 2 weeks or 3 weeks, there is going to be some kind of lockdown again. So am I clear or should I repeat?
I think, no, it's clear. I think that decision has to be taken after 20th April when there will be a staggered lockdown or some services would be opened up. And I believe the hospitals will be allowed to function after 20th April.
No, hospitals are allowed, but you have to take yourself, see, if you get positive patient, they might quarantine the whole hospital and close down the hospital. I think that's what he's saying. COVID is not going to disappear. So I think the best thing would be to get an elective, as Partha was saying. I think I have talked to a couple of labs in Delhi. They are willing to, with your signature, the reason for getting the test done is because they are going in for a surgery. So I think we should get an elective COVID test done and then let the patients come in for the OP. But the question is that you can't have an elective test done for all OPD patients. So that's going to be a problem.
Mahipal sir, tell me just in simple questions. There are so many tests of the COVID to make it very sure.
Which one would you do? Which
Can I make a comment here?
Yeah, Malik.
Yeah, see, if you do a COVID test, it's actually a double-edged sword. The positivity rate is only 75% sensitivity, 70%. Supposing there is a false negative and you have operated the patient and then later on becomes positive, now he has a proof that he had come in uninfected and you infected him. Whereas it was actually a false negative, which is very common. So actually it's a double-edged sword.
So can I say something?
But still,
here?
in 75% of situations, you will still be sure that it is positive or it's negative.
No. So
But 25% is not a small number.
But Malika, how can he prove that he got it from your hospital and didn't get it from elsewhere, not got it from home?
That applies in any case, but now he has an additional proof that he was negative.
Malika, can I say something? What my take is that if once the serum test comes in, we should be doing the serum test. Once an antibody is there, that test is most sensitive. So anybody who is antibody negative, so we look at both IgG and IgM. In those cases, we do the RT-PCR.
No, but
Antibody becomes positive later in the course of the disease.
So once you're doing that,
I think this question will be best answered by a virologist, and we will have to take help of the virologist and psychologist in the next.
Regardless of whatever we say here, the state government doesn't allow us to do the test. In Kerala state government, they have a clear-cut list of guidelines. What are the indications for the COVID test? And preoperative, it's, am I audible?
You are audible. Tests, nobody is allowing.
Is not allowed. Yeah,
it is not allowed.
It is not part of the indications of COVID test according to the state government.
Having said this, a lot of private hospitals in Delhi, which include Gangaram and other hospitals, they have said that they will not take these. Will not take up surgeries if the COVID test is not available.
Namrata, can I say something?
Yeah.
Yesterday morning, there was a direct communication between UCSD San Diego with Wuhan and Beijing. And what they said was that all patients who are taken up for surgery, it was eye department, the president of the Chinese Ophthalmic Society, he said all patients who are being taken up for surgery, they are being tested for anti-COVID before they take up the patient for surgery. Another thing they said is, before this epidemic started, people who are getting maximally affected were either ophthalmologists or neurosurgeons.
Okay, Dr. Santosh wanted to say something, and then Rajesh, you tell us the response.
We are yet to receive response from Dr. Natarajan, Dr. Lalit, Dr. Karan, Dr. Ajay, Dr. Sri Ganesh, Dr. Arup, and Dr. Ramurthy.
I have replied.
Rajesh, one of my patients asked me, is your staff tested or not? Because they are also coming. You see, my OT staff, my technician, my nurse, are they COVID negative? The patient asked me that, आप हमसे करा रहे हो, आपका हुआ है? So that's also a relevant question.
Yeah, Santosh, you wanted to say something?
Yeah, I checked with ICMR today. They are not permitting any routine tests at all. It is illegal actually to do a test on asymptomatic patients. There are only 5 conditions which are permitted to be tested. Beyond that, if you do a test, then that is illegal.
Illegal.
Yeah.
Illegal to nahi hai. They are not illegal.
No, you cannot do it, sir. You
not
cannot
indicated.
fill a form.
No. I have got it. Santosh, I have got it done on asymptomatics. And we are doing.
You cannot do it.
Sir, it's not feasible. First of all, this is not feasible. So let us think something which is feasible.
See, when nursing homes are saying that no surgeries without COVID testing, anesthetists are not willing to give anesthesia.
Then they can't do surgery. It's simple because ICMR is only 5 criteria under which patient can be tested. There is nothing that you can add to it. You have to declare you have to give a wrong declaration in the official form, which amounts to cheating. You cannot.
There are quite a few private labs which are authorized to do the testing, and I do not think there is any legal provision that bars a person from getting.
Yes.
And from now, they have started doing random testing on patients who do not even have COVID symptoms to see the sampling of the country.
That is under a research protocol. That is done by ICMR, not by individual hospitals.
Okay, fine. Dr. Rajesh, can you just answer whatever you have of those slides?
So far, we have 9 responses, and out of these, 4 have told that it will take about 12 months. 3 have told that it will take 6 months, and 2 think that it will be, within 3 months' time, it will be, near normal.
And sir, there are responses by the people who are listening to us also, and most have said 6 to 12 months. In the admin, the answers that have come in.
Okay.
Can I ask one question to the panel? Since many of you all are heads of institutions, what are you all doing practically as far as patients who pay by cash goes? Of course, we're trying to get digital money wherever possible. But if a patient comes and pays in cash, I'm sure banks are working. How are you all handling it as far as, for fomite issue goes?
So actually what the banks are doing, that they are making gloves for people and they can discard them. The people have kept a steam iron. So they pick it up with a tong, put the money and iron it, and so that the nice. So that I saw was there. But otherwise, I think gloves is what is required. That is something which is there.
So we can take gloves and we can leave it untouched for a few days. Leave it untouched for a few days. And then
Malika, it will not remain.
So I have a suggestion which we have been thinking of doing. I do not know how far is good. You have gone to barbers for the haircut. They have these small ultraviolet chambers. So we get those chambers and put the money in that, and the ultraviolet, the UVC works, and that is all that will be required.
No, but pulmonologist told us that the UV radiation doesn't get you rid of the virus.
No, but I tell you, this is from New York, New Jersey. The N95 masks are being sterilized by UV radiation. So they are given paper bags. They go to the facility, give the N95 mask. So if N95 can be done, why not the money?
So how about ETO?
No, not ETO, UV light. Because my own cousin sister, she's heading Rutgers University.
Yeah.
They are doing it.
Yeah, people are using UV light for this.
Yeah, they are using it.
So,
sir, I have one more question, if you would allow me to ask.
Yeah.
So I have one more question, if you would allow me to ask. Being a cornea surgeon myself, and right now working in a place where there is a lot of, last week only we had 4 eyes with perforated ulcers coming, of which 2 of them were auto-eviscerated. So what would be the current status of eye donation in the country post the lockdown? Could this be done that, only eye donation can be done in hospitals, big hospitals like AIMS or like medical colleges, where the patients have died because of natural deaths or some other causes and who are COVID negative? Can this be some solution to taking this forward?
I can answer that, Karan, for you. From the Eye Bank Association of India, we did take out an advisory saying that eye donation has to stop because all the eye donation counselors have to go to the mortuary where there are a lot of patient deaths and we don't know which is COVID positive or which is not. And in the tear samples, it has been shown that, the virus may be there. So what was done was that all the eye banks, they have collected till that point in time, till the advisory was sent and till the government also put a stop to it. Whatever eyes were there, they were in cortisol, and after a few days, they were shifted to glycerine. Glycerine preserved eyes can stay for about 1 year. So you can ask any of the eye banks, even our eye bank, Shroff, Charity Eye Bank, and LVPI, all of them have glycerine preserved eyes which can last for 1 year. And all these cases which are therapeutic, where there are perforations and you have to undertake a corneal transplant procedure, you can use these glycerine preserved eyes.
Okay, last 2 questions, Dr. Namrata or Rajesh, if you have seen I stopped scanning them. I think there were a couple of questions on telemedicine. I think we formed a group that is going to look at the commercially available tele-ophthalmology platforms, and AIOS could negotiate with them and tell you as to which tele-ophthalmology platform will be there. Any other question, Namrata?
Sir, I think we have answered most of the questions. AIOS coordinated telemedicine.
I just have a doubt that you might ask this. I mean, there's been a lot of controversy about this usage of PPE. I am personally of the opinion that unless we get a COVID positive patient whom we are forced to operate upon or take care of, PPE is not necessary in normal ophthalmic practice once the ban is lifted and we can go back to work. I think we need to arrive at some kind of a consensus on that.
Some of the cases you might still require PPE. For instance, if you are doing under general anesthesia, intubation, extubation, all those things are there.
Talking about when you are seeing normal OPD practice, if you ever
Normal OPD practice, probably you don't require a PPE to.
Yeah, I guess we have to rule out COVID positivity, because if it's COVID positive and we are using PPE, then while doffing PPE, while removing it, we can contact infection. That is the most dangerous, and it is always done under observation of a trained person, doffing of these PPE. So that is why I guess more testing, COVID testing will be more useful than having PPE in these areas.
No, but Dr. Rajesh, if you have a patient who is COVID suspect, it's better to send the patient to a hospital, which is COVID hospital. There's no point.
But this patient has to be sent to a proper hospital wherein a trained personnel sees how you are donning and how you are doffing the PPE, and this PPE has to be kept in a place wherein then there's a proper procedure that is followed in donning and doffing. So in such a hospital, that can be
as regards the, can I talk? As regards the PPE.
Ramurthy, you see that for a routine ophthalmic surgery, which includes detachment and glaucoma surgery, cataract surgery, PPE is not required. Let us not exaggerate this.
No, Lalit, I am also of the same
only for COVID positive patient, and that in any case, like Rajesh said, we have to refer it for a multi-specialty hospital.
No, I am completely agree with you. That's my opinion also. But some of the speakers and even otherwise, when you talk to them, they keep talking about PPE. I think for a normal routine ophthalmic practice, once we become functional, PPE is not necessary.
So let Namrata come out with this.
Yeah, we should have guidelines.
So,
as regards the PPE, there is so much variety available. We need to standardize.
What we can do is just
the quality of the PPE.
Just before 20th April, we'll hold another one on the practical aspects as to when the lockdown is staggered or when we have to open, then how we have to proceed with it. We can do yet another webinar on these small things, how to dilate the eyes, whether the attendant should do it or the patient himself should do it, or whether there are a lot of other of these ancillary questions on day-to-day kind of activities which we can come out with, and also can make a standardized video for all the members to see so that they know what to do.
Dr. Namrata, I have a question. Can I ask?
Okay, that will be the last question, Ajay.
Yeah, repeatedly is being mentioned that when you are operating, there should be no positive pressure ventilation. I am of the opinion that we should have the HU running. We should have HEPA filtration. So I think this should be very, very clear. We have had this discussion many times. And even the pulmonologist said that we should have the HU running.
So we will have all these group of people in that, pulmonologist, virologist, and people who are dealing with the infection control. We will have representatives of these people who will guide us as to how to now practically take this, how to come out of it, out of the COVID era. So we have agreed that we are going to have a AIOS coordinated telemedicine platform, AIOS psychological help platform, and besides the other things that have been already promised. And with this, can we conclude the webinar?
Yeah, I think it's been a great.
There was a question I had one which Mahipal had said about the time period.
Okay.
On WhatsApp, I had replied, no. So what was the outcome?
That he has already said.
There were some more responses actually. I can tell you, sir, that there were 4 responses which stated that it will take 12 months. 2 responses in favor of 9 months, 4 responses in favor of 6 months, and 2 responses in favor of 3 months to achieve the near normalcy that we'll have after this COVID.
So we are all kind of, it's a
so mostly it is between 6 months to 12 months. Most of the responses are between 6 months to 12 months.
So to conclude this, we would like to thank all the speakers. We are particularly thankful to Dr. Mahipal Sachdev for getting Mr. Kaustubh and Mr. Kashyap on this webinar, and Dr. B.K. Naik sir for getting Mr. Vajpayee, whose inputs have been really useful for not only the people who are listening, but also for us as the panelists. We would like to thank the guest faculty, the entire panelists, the Governing Council of All India Ophthalmological Society, Dr. Ramamurthy, Dr. Sri Ganesh, Dr. R.C. Paul, Dr. Malika, Chaitra, Preetham, and Dr. Karan Bhatia. Then we would also like to thank our sponsors, Johnson & Johnson, for doing this for us week after week without any financial strings attached to it. We were on Facebook Live, YouTube Live, as well as website logins, and we will come out with the figures. The figures have been quite high. So thank you, everybody. And we would like to thank our AIOS team at the AIOS headquarters, Kripal and Rakhi, for making this happen. And thank you all the people who were watching it and all the people who responded to both the surveys, the AIOS survey as well as the IGO survey, without whose input we would not know what the real situation is. So thank you, everybody.
And I think final,
yes,
the surveys have still not ended, so you should please sending your responses because the surveys are on till 19th. Thank you, everyone, and stay healthy.
Okay, bye. Thank you, thumbs up to Mahipal, Namrata, and the entire team.
Thank you, and thank you for wonderful inputs.
Yes. Thank you, everybody. It was great.
So
Thank you. Thanks a lot. Good show.
Stay home, stay safe, stay healthy.